Good morning, everyone. I see the left side is noisier than the right side. Okay. Hello, and hope that you have a good rest this evening. This day is going to be very amazing. So many things to hear, and I would like to welcome all of you to this event, and grateful also to those joining online who are not able to make the trip to Tanzania. So today's event is entitled Thrive, all to thrive NTD Progress Challenges and Learning Event. This means that we're looking to what has been done, what has been achieved, but we're also looking forward. And that's very, very important. Building on what has been done to prepare for the next steps is important, I think, in the world of NTD. And we are delighted to have so many people joining us today, both in person here in Dar es Salaam, Tanzania, and thank you to Tanzanian people and colleagues for the effort you put on making this event happen. We have also colleagues joining online, and thank to those who, due to time difference also, try to make it happen and joining early in the morning in some of the countries. You will hear many people, especially government officials, talking about experience. We'll hear from partners. We expect also to hear from all of you in terms of contributions, questions, to bring your experience in this conversation. So thank you also for preparing for that and paying attention to the discussion and what you will bring back home. My name is Justin Tin. I'm the Health System Strengthening Lead in the Act to End NTDs program, and I will be facilitating some of the transition for today. And hopefully also there would be very active participation from all of you. But before we go any further, I want to make sure everyone also knows that we have English and French translation. So try to be very inclusive today so everyone can, based on preferences also, connect to the channel that suits to him. And when you speaking also, you'll be able to speak in the language where you feel comfortable or you think that your message will be heard very well. So those who are in line, there is a button where you can select the channel of your preference. Those who are attending and you are in the room also, look at the headsets. There's channel 1 is English, channel 2 in French. If there is any issue, ask to your neighbor or ask to our team also. They will directly and help you also to select the right channel. I think everything with the headset, there is not much difference between what we did yesterday and before yesterday. So hopefully, if there is any issue with some of the items that are working, please refer back to the team. They will change it. Okay. Ready? Ready? Oh, that's good. Okay, that's good. Okay. So we will be starting soon. Our guests of honor are around. So we would like you also to make some effort and standing up to welcome them officially, but also for us to exercise. Please stand up. Stand up. So they will be arriving from this door. So don't look at to me. Try to. Okay. Thank you all, and thank also to the team for this warm welcome. We're starting our session right now, and with the welcome words and the opening. And done. So we'll start with our first speaker, and I would like to welcome Deputy Health Director Hannah Hoffman from USAID Tanzania, who will provide us some welcome remarks to start us off today. Ms. Anna, welcome. I would like to welcome you, and please.
Good morning, everyone. Karibu Tanzania. We are very happy to see everyone here. I want to specifically acknowledge the Director of Curative Services. Professor, but I've also just learned that you are also a doctor. So you are one of the rare people who gets both the professor and doctor title, Pascal Lugajo, who is our Director of Curative Services here. Also, Dr. Kabona, the Program Manager for the NTD program, our colleagues from Peel Raj, the President's Office of Local and Regional Government, and all of you, really. I hear that there are Ministry of Health representatives from over 30 countries. You have come to Tanzania, and we are so grateful. I imagine for many of you, it was very difficult to travel here. So we welcome you to today's event, which is focused on NTD progress, challenges, and learning. Really to have all of our Ministry of Health and government representatives, also representatives from the ACT East, and I understand the ACT West. Of course, we are biased to the ACT East being here in Tanzania program, but also for those of you who are from the project, other perhaps USAID staff, distinguished ladies and gentlemen, as we say here, all protocols observed, and also, of course, our colleagues from USAID Washington. As they said, my name is Anna Hoffman. I am the Deputy Director here for USAID Tanzania's Health Office. And you know, it's really special for us always to have people in Tanzania, and especially to take this moment to, I hope, collectively celebrate really all the gains. And I was just very impressed hearing Dr. Kibona talk about all of the progress that's been made here in Tanzania, and I know in many of your countries as well. I started my career as a Peace Corps volunteer, as a water and sanitation Peace Corps volunteer in Ghana. I don't know if anyone is here from Ghana. I thought I saw a name, maybe. Yes, welcome. Nice to have people from my my Peace Corps home country. So when I started my career, I remember learning about soil-based helminths, about bilharzia. I was in the Volta region, so it was, bilharzia was very endemic there. And really a lot of our focus was just about education and school programs. And this is before any of the USAID support really existed on this large scale. And to see the difference from that point until now is really just astounding. I mean, I think the partnership between our government colleagues, the private sector and pharmaceutical donations, and USAID, and really the US Congress really supporting this, I think has led to a world where we actually aren't just imagining elimination, but are actually achieving elimination of many diseases. So yeah, I think that really deserves a round of applause for all of you who are in this room. Because I know that you all with your colleagues back in your home countries are really the reason for that progress. So I hope that you all take some time to celebrate that. I think that this as a moment sort of pause. At USAID, we often talk about pause and reflect, and this seems like a particularly good moment to see all the progress that's been made. But as we were just discussing, there still, of course, are continued challenges. There are still elimination or control yet to be done, and also one of the things that we're really talking about here is then sort of what next? How do we make the work that we do sustainable? How do we integrate into primary healthcare so that these achievements aren't lost, and so that we really think about holistic services for people that are both about prevention, treatment, care, and surveillance to make sure that we are really understanding what the picture of neglected tropical diseases alongside all other diseases look like. So I really think this is such a great group to be together, to be talking about that balance. I think we've spent really, for good reason, a lot of time saying, we're going to eliminate. And now our conversation really turns to really this very close work with the government, which is how do we sustain the gains? How do we continue to work towards where we still have challenges? And also, how do we ensure that the next 3 years, I believe, of the project are such that whatever comes next, it really looks like new generations, a different world, and a world in which we have a lot of integration of all of the work that we do. So I welcome you all to today's event. Thank you all for staying an extra day from the conference from the past few days. And really, again, I'm so grateful to have our ministry, our government of Tanzania colleagues, all of you together to have this important conversation. Thank you so much. Asanteni sana, as we say here.
Thank you, Anna, and be assured that we hear you. Let's collectively celebrate, because I'm pretty sure that if you were about quantifying so many effort government partners have put on this exercise through the elimination, none of us will get the mathematics right. None of us, I'm sure. So let's celebrate and build upon that to look at the future. I would like right now to welcome Dr. George Kabuna, the National NTD Program Manager within the Ministry of Health, who will welcome our guest of honor. Dr. Kabuna, please.
Thank you very much, and it's a great pleasure and honor to just given an opportunity to introduce our guest of honor, Professor Pascal Rugajo, the Director of Curative Services at the Ministry of Health, Tanzania, the mainland, and also representing the Chief Medical Officer, Professor Tumainag, who was supposed to be with us, but is on another equally important activities. But we all know the Ministry of Health, how much is committed to eliminate NTDs, and the Chief Medical Officer has been instrumental and demonstrated some important commitment towards improving the curative services at all levels, including the primary health facilities, which at the stage where we are, it's an area where we can easily strengthen the diagnosis, treatment, and case detection on the cause of NTD implementation. And therefore, today, Professor Rugajo is ready to address us and share the impressive perception of our efforts toward NTD elimination. Therefore, I take this opportunity to invite the guest of honor, Professor Rugajo, to address the audience. Guest of honor, you are welcome.
Good morning. Yeah. So, Assistant Director of Health, Social Welfare and Nutrition from the President Office, Regional Administration and Local Government, Dr. Paul Chaote. You know, the health sector moves as the Ministry of Health that sets policy and guidelines, and POLAG that implements and sets the interventions, especially at the primary healthcare, where more than 85% of our population seek healthcare. So we always move together. The representative of the Regional Medical Officer of Dar es Salaam, if he's around, the Program Manager for the National NTD Control Program, Dr. George Kabona, USAID Deputy Director of Health, Anna Hoffman, the Senior Public Health Advisor for NTDs, USAID Washington, Rob Henry, Senior Director of the USAID Act to End NTDs East, Risa Rotondo, representatives from different countries, I'm told it's more than 54 countries, and in this room, members of the media corps, distinguished ladies and gentlemen, protocol observed, Jamhuri ya Muungano wa Tanzania, you're subdued. So we repeat again, Jamhuri ya Muungano wa Tanzania. Excellent. So welcome to the United Republic of Tanzania, the land of Kilimanjaro, Zanzibar, and Django Safari. But also welcome to Tanzania, the East, Central, and Southern African regional hub for medical excellence and medical tourism. We thank Almighty God for this day, but also for his graces that enabled us to assemble here today. It is so heartwarming that you made safe journeys here, and I believe you are going to take a lot of memories back home. Would like to thank Her Excellency Dr. Samia Suluhu Hassan, the President of the United Republic of Tanzania, who is the champion of the renaissance of healthcare in terms of investment and delivery in Tanzania. We are all, we can all testify the investments in terms of infrastructure, human resource, equipment and technology that has been set over the last few years. And this kind of reiterate Her Excellency's commitment towards improving health and towards improving the quality of healthcare. Receive heartwarming greetings from Honorable Umi Ali Mwalimu, Member of the Parliament and the Minister for Health, and the entire management team at the Ministry of Health. I would like to appreciate the USAID Deputy Director of Health for the kind words that she has said. And we thank all of you in this room for being ready to participate and discuss, reflect, and strategize towards strengthening and upping the game against NTDs. So I have a singular honor on behalf of the Chief Medical Officer, Professor Tumaini Nagu, who had enough faith to send me to represent her here. And she would like also to welcome all of you to Tanzania. And she appreciates and underscores the collective efforts that all of you are showing towards eliminating NTDs. As you are all aware, Tanzania has worked hard to control and eliminate the devastating and debilitating effects of NTDs that afflict our population. And I'm told the thresholds for eliminating NTDs are very strict and stringent, 0.1%. But I was heartwarmed to hear that Benin and Mali has made it possible. Take it from me, if they have made it possible, we are on the home run, we are on the home stretch towards victory. And I'm sure it's just a question of time. And judging the enthusiasm and the minds and hearts that are in this room, I feel that you came at the right time, the right group to discuss the right strategies for eliminating NTDs in our country and the countries around us. Did you ever know that Tanzania is privileged to be geopolitically, geographical, geohistorically, and geoeconomically at a place on earth that is very strategic? And when you collaborate with Tanzania, you collaborate with a bigger region around Africa. Not many countries in the world are surrounded by 8 other countries. And Tanzania, as I said, being the hub for medical excellence and an upcoming center for medical tourism, is once you collaborate with Tanzania, then the spillover effect to other countries is really palpable, and it's the best way to collaborate with the entire Africa. So welcome to Tanzania. I am aware that it would be impossible to fight NTDs without concerted effort and strong partnerships. And that's why I applaud the partnerships and partners that are in this room, that include governments like the United States of America and other donors that have supported us with different programs against NTDs over the years, and who remain committed to give financial and technical assistance towards eliminating NTDs. But I'm also aware that without the public-private partnership, it would also be difficult to fight against NTDs. So I also applaud the private sectors, NGOs, faith-based organizations, and others, voluntary agencies that are all aligned and are partnering with our government to fight against the NTDs. But as I said, we also have local and international NGOs who have done a lot of extended surveys on NTDs, and in one way or another, they are contributing towards these concerted efforts. But heartwarmingly, I also appreciate the presence of our peer countries. We all know that NTDs, by and large, is a tropical problem by far. But if you look at across the room, you see all colors, creed, and ancestry of people aligning together and foregoing their priorities and making sure that they align their resources to fight against the NTDs. And for that, we really appreciate. So I'm very much thrilled today that you are here to share the lessons, reflect on the progress, but also recommit ourselves again as we forge our way towards eliminating NTDs. So Tanzania as a government reiterates its commitment to ensuring sustainability and inclusivity of all different NTDs efforts. In the year 2021, we released 2 new 5-year national plans that chart our way forward on how we are going to achieve this. And we know this is also impossible without consultations, partners, program, and other stakeholders who are represented in different forms through all of you here. So our sustainability plan and strategic master plan for the NTD program give us the sustaining gains that have been made. And I'm sure this is the right forum to discuss what has been gained, how can it be sustained, and how do we pave new ways of making it even more impactful. But we also know that this is the era of integration, and integrating NTD services into our health system is a way of making it sustainable and make good, optimal use of resources that are around, especially the human resource that is always scarce in our tropics. But I think integration is the way to go. And so we are so happy that increasingly NTDs are being integrated in our day-to-day care delivery. So I'm sure there are plans that will highlight the importance of monitoring and evaluation. It's always good to take stock of where you are, look at the resources that you have, optimize them, and even bigger results. So I'm sure you will share surveys, you will share data, and you will also into data quality and making use of the research into improving clinical care, prevention programs, rehabilitation, palliative, and all parts of the treatment chain. So I'm sure there are plans that are built on achievements, and our first NTD master plan that was launched in 2012 is also getting a lot of feedback from what is being achieved. And upon review, it is being improved as we go forward. So I'm told that we have made significant achievements in understanding the disease burden and planning and implementing control for interventions. So we are proud that more than 580 million treatments have been delivered, and more than 800 surveys have been conducted to assess the impact of different interventions of NTDs. But we have also reached full coverage of mass drug administration in all councils, reaching over 42 million people with treatments for NTDs. So this is probably close to 75% of our population, and we are not settling for less. I'm told, and before coming to this large auditorium, I had a side meeting. You can see the energy, the enthusiasm of partners coming together to make sure that we attain full elimination. But we have been able to scale down mass drug administration for lymphatic filariasis and trachoma as we approach elimination, to single out just a few conditions. So as a result, the prevalence of highly endemic diseases is going down, and we hope we'll be able to sustain the elimination as far as it takes. So these achievements, as I've said before, have been made possible by the collaborative efforts of the local communities, government partners, and our implementing partners. So I would like you to continue, sustain the partnership, do research, translate the research, do monitoring and evaluation, and every time give the feedback into the loop to improve what was existing and what has been achieved before. I'm sure all these achievements are not without challenges, but challenges are there to be surmounted. So with every challenge, you become stronger, and I believe you are discussing here, and you will share a lot of experiences and how you have individually and collectively solved them. So many of you as well, I encourage you to share these challenges and lessons, because it is probably your problem is someone's solution and vice versa. So probably sharing is the best way to take stock of what is happening, but also strategize of how to counteract local problems and get global solutions. In recognition to the progress made, challenges faced, and lessons learned, and the opportunities that lie ahead, our new NTD Strategic Master Plan prioritizes the following areas or thematic areas as we move and push towards elimination. 1, strengthening government ownership, advocacy, coordination, and partnership. 2, enhancing planning for results, resource mobilization, and financial sustainability. 3, scaling up access to interventions, treatment, and system capacity building. And 4, enhancing NTD monitoring and evaluation, surveillance, and operational research. So these are like the thematic areas which we believe if we put our focus, our resources, and our priorities, we are going to get even bigger gains. So as we move forward, we must work together to ensure NTD services are sustainable and reach the last mile or the poorest section of the population, or at least reaching the most vulnerable groups or sectors in our population as well. This is the key step in achieving our aspirations for a healthy, productive society. And I liked the spirit that USAID for all to thrive. So we'll be also living by this adage or mission. We also know that NTD Progress can have a ripple effect and a multiplier effect through our societies, furthering progress towards not only the World Health Organization targets, but also sustainable development goals that we have to say we are struggling to reach, but they are not insurmountable. So as the world considers on how to get back to achieving SDGs, it is now the perfect time for us to discuss NTD progress and what can be done further to improve the tangible outcomes. I'm looking forward to the conversations that will take place here today, and I'm sure the exchanges will be very useful. And I'm also very confident that from the exchanges that you are going to have, you will have a bigger feedback towards our policies and guidelines to improve them as we reach 100% of elimination. That should be the target. So with those few remarks, I wish you a productive event and enjoyable stay during your time here in Tanzania. I hope for those of you who come away from here, they'll have time to enjoy the hospitality and probably a few sightseeing. Close to here, there is a Dar es Salaam Zoo. At least you can go back and say you saw a lion. Okay. Yeah, so I wish you a very enjoyable exchanges, sharing of lessons, and I declare this sharing meeting officially opened. Jamhuri ya Muungano wa Tanzania, asanteni sana.
Thank you, Professor Rugajo, for the opening and for also the content of your message. Thank you. George, Dr. George, I've seen that you have been very, very busy, a busy man, 87 surveys. Adding to what you are doing in the network of program manager in Africa, thank you. And let's a second round applause for Tanzania. So we'll pause for a few minutes to really take this opportunity to put this also on the memory. So we, with your permission, Professor, would like to have a group picture. So if you can have a few seconds of music also, would be great. Okay, so please. Okay. Professor Please have a seat here. Professor Rugajo, please share our thanks with the Chief Medical Officer, Professor Tumaina. Our greatest thanks to the government of Tanzania also for hosting this event. I've been impressed by the visa processing and how to get to airport. Honestly, that's fabulous. Thank you. Okay, so we'll stand up and give opportunity to our guests also to stand up for us. Okay, so let's start and try to put in practice also the message we received from our guests about sharing and take opportunity of what also the representative from government of Tanzania said. The challenge of one can be the solution for another. So let's use this opportunity really to go in deep in some of the things we know and be also willing to share. So the U.S. Agency for International Development has been a leading donor in NTD control and elimination since the launch of the program in 2006. We will now hear from USAID, Darren Evan, who will share about the past, present, and future of USAID support NTD. And we're grateful also to USAID for accepting to share about their thought for the future for NTD. This is very important, I think, for all of us. So Darren, we welcome you.
All right, thank you, Justin. And before I jump into the slides, I want to just pick up on the sharing concept and share a little bit of credit here. I'm going to spend the next few minutes talking about USAID's history of support. But I want to make very clear that while this may seem self-appreciating, this is really an accomplishment of not just the donors and the pharmaceutical partners, WHO, the implementing partners, but most importantly, the country partners who have really been the boots on the ground and the ones to drive the leadership in this space. So giving credit where credit is due. All right, so most, if not all of you, are familiar with USAID's NTD program. I'm getting signals from the front here, so forgive me. And I'm going to talk a little bit about it. The NTD program, as we know it today, really, as Justin alluded to, began in 2006 with funding from the US Congress, and implementation began in 2007. Over the last 18 years, the program has grown almost exponentially, expanded. And with that growth and expansion, there has been an evolution in the focus of the program, including not just in its strategy, but in how we support the programs going forward. Most of you may not know that USAID's history in NTDs actually goes back much farther than the NTD programs. USAID was one of the original supporters of the onchocerciasis control program, later APOC, but they also not just invested in regional initiatives, they did country support for things like onchocerciasis, leishmaniasis, trypanosomiasis, and guinea worm, among other NTDs. So it's really a space that USAID has been working in for quite a while. The NTD program specifically focused on the 5 preventive chemotherapeutic diseases, but it was different than historic approaches. It wasn't focused specifically on the diseases themselves, but rather the platform, the strategy for delivering the medicines to target those diseases. And as such, leverage the drug donations that were available. In the very beginning, it was very much a proof of principle. We wanted to show that an integrated, co-administered strategy for safely delivering medicine could be accomplished at scale across multiple countries and at minimum costs. The program began in what we called the 5 fast-track countries. These were 5 countries that had initial pilot projects being supported by the Bill and Melinda Gates Foundation, and later, over the course of the next 5 years, expanded to an additional 10 new countries. Its original mandate was to provide 160 million treatments to 40 million people in 15 countries. But by year 3, the program had far exceeded those goals and providing 224 million treatments to nearly 100 million individuals. And that continued to grow. And by year 4, in just the 10 new countries, not the fast-track countries, they had reached 170 million individuals, providing 390 million treatments. And importantly, they were able to leverage over $2 billion worth of donated medicines. And this was important because this was to become USAID's largest public-private partnership. In the beginning, the strategy was viewed by some as an if you build it, they will come. If you are able to provide support to get medicines delivered to endemic communities, then it is simply a matter of getting those communities to take the medicines and you will be able to achieve the elimination goals of the programs. But it was much, much more than that. There was a whole series of wraparound activities that were required in order to ensure not only that those medicines could be delivered, but they were done so in an effective manner and that they were maintained over time. This included the initial work of planning and collaborating with national programs, rolling out the actual strategies, developing M&E system, doing mapping, and establishing a centralized coordinating mechanism that had within it the capacity strengthening, training, and supply chain management skills necessary in order to maintain programs moving forward. And this wraparound support in the very beginning was very much focused around the country programs. We move forward into our next phase of expansion, the next 5 years, where we went from 15 countries to 32 countries, including the OAPA countries in Latin America. And we had a rapid increase again, moving from 70 million persons treated per year to nearly 200 million persons treated per year, 400 million treatments per year, and a sharp increase in the number of impact assessments, going from a couple of hundred annually to more than 1,000. Importantly, during this period, 95 million people no longer required treatment for LF, trachoma, and onchocerciasis. Many of you may recall this graphic from our 10-year anniversary. This is showing, basically representing the large scale up of our investments during that period. By 2016, we had reached our 2 billionth treatment, leveraging $11 billion worth of donated medicines. With that scale up came scale up in investments in that wraparound support, moving from national support to global support. We had new investments in operations research, in tool development. We had investments in DNDi for new medicines. We had a morbidity management program looking on new tools and strategies to help move programs towards the dossier. And we had our support to the global strategy through WHO. But that was not just to WHO, it wasn't direct support, and it also included indirect support. And that indirect support came from many of you. Those investments through country research projects, through our implementing partners, came out with things such as the NTD Toolbox, the mini tasks, the tool for integrated planning and costing, coverage evaluation surveys, supervisor coverage tool, and much, much more. Jump forward into our next phase, acceleration. We had expanded into our full countries, and we were looking at pushing those countries towards their elimination thresholds. At this point, we began to see a lot of variation in the number of treatments that were being given. We ranged from 400 to 100 million. This was during the pandemic, but more significantly, this was also a period where we began to see a great deal of success, and we were able to stop treatment in a vast number of communities. With this expansion came an evolution in innovation and the wraparound support that I talked about. In the early stages, we were focused on feasibility and access to the drug donations. Later on, we began to look at research to remove barriers, protect investments, accelerate progress. We had our drug development investments, our morbidity management. But as we moved into the acceleration phase, we began to see a shift in our priorities. We are now looking at increased access, sustaining the gains and protecting our investments. We began to move from drug development into new diagnostics to try and increase access and improve our ability to measure impact. And we went from helping support health systems to develop their morbidity management programs to a broader approach towards sustainability and delivery of from within the health systems. This is just a cross-section of the investments made during these periods. You can see that by 2016 to 2020, the phase 3, we had leveraged over $16 billion worth of donated medicines at a cost of just over $500 million. Throughout this process, our core support has actually been fairly steady. 75% of all our investments go directly to the country programs. That's the vast majority of our investment in this space. However, the other 25% is focused on strengthening the programmatic and scientific evidence base and the global leadership. This is that wraparound support that I talked about. However, our main platform has maintained itself throughout this process and continues to move that way. Moving forward to the present, we are now looking at documenting the progress through dossier submissions and achieving elimination. We now have, I think it's 13 countries with 15 dossiers. 5 countries currently have dossiers that are either under review or under development. We have nearly 700 million treatments that are no longer required. And with that shift towards sustainability, we are looking at countries to developing sustainability plans, and we have 12 countries that have those finalized or in draft versions. Our strategic objectives, maintaining a focus on the national strategies. The implementation is still the primary activity, but we have a strong interest in strengthening the scientific and programmatic evidence base and allowing that to evolve with the needs of our implementation practices. We are looking very strongly in the sustainability space and supporting country-led programs to reinforce national governance and strengthen their health systems. And throughout all of this is the growing and expanding partnership that involves many, if not all of you. Looking at progress in terms of number of treatments, you can see that in the first decade of the NTD program, there was a rapid scale up in the number of treatments, particularly around LF and as a byproduct, soil transmitted helminthiasis. And around 2016, 2017, we see that rapid decline. This is the success of those programs, achieving their elimination targets and being able to switch off the MDA strategies. You'd also note, besides the pandemic dip, that there is a significant growth in our onchocerciasis treatments. After the closure of APOC, we were able to rapidly scale up our pressure on the onchocerciasis parasite. This was almost entirely led by country decisions to expand treatment and increase drug pressure to try and drive down infections. This past year, we treated as many onchocerciasis, we provided as many onchocerciasis treatments as all other treatments combined. So that represents a significant part of our portfolio. Just to give a little bit of context of where our investments are on the global stage, in terms of lymphatic filariasis, and I'm talking just about number of countries, not in terms of total burden. We support about 40% of the global LF endemic countries, almost 30% of the trachoma endemic countries, and 56% of the onchocerciasis endemic countries. This is a snapshot of those 13 countries that have achieved elimination, the 15 dossiers. Very exciting. Niger is on track to become the first country in Africa to be verified for elimination of onchocerciasis. I understand that they're having their review sometime in the next month or two. And that will be a leader, I think, in a wave of countries that are going to be able to begin to submit dossiers for onchocerciasis in the Afro region soon. The wraparound support continues to grow and evolve. We have, of course, our operations research supporting global policy. We're looking at the new and improved diagnostics. We have investments in new research, new surveillance strategies. We provide technical support for the development of WHO manuals, including the LF M&E manual, the recent MMDP manual, microplanning, and other things. We also help support human resources, not only in the forms of staff positions in WHO, but also in terms of support from our own staff, as well as our implementing partners who assist in the writing and development of much of this guidance. On a national level, we have many of the same investments, although more focused on national needs. In the operations research space, for example, we're looking at migratory and populations, which were alluded to a little earlier this morning. Persistent, I'm going to say persistent untreated. I think non-compliance is not quite the right term, but trying to figure out how to reach those people who are not being reached for treatment. We provide technical support in the form of national advisory committees. These have been hugely successful, not only in working with countries to understand their epidemiologic situation, but also in promoting national ownership and leadership. We have human resource support through various mechanisms such as secondments, training, and capacity strengthening. Our investments in the global strategy are evolving, as I said before. Whereas we used to provide a lot of support directly to Geneva, we are now looking to support some of the regional offices that are closer to the countries where support is needed. This is largely focused on filling in the implementation gaps in those areas, leveraging some of their technical expertise, particularly in terms of how we might strategically invest in some of the non-PC NTDs and leverage some of the platforms for monitoring and existing platforms for monitoring and evaluation. So what are we thinking about the future? Well, I think we will continue to try and tackle the final mile issues. This will be a process for as long as we have elimination programs. There's always going to be challenges that we're going to need to address. But we're also going to start to look at how we can understand better the global and geographic gaps that are needed to be looked at, and where our research and development needs are going to lay. Importantly, we are looking at how we can leverage our historic investments and our current platforms to strengthen some of the non-PC or non-MDA services, and explore some of those opportunities for changing how we provide assistance. So what do we need for that? How are we going to facilitate this? Well, as I alluded to at the beginning of this is not just about USAID. This is about the broader partnership. And those partners play a significant role in shaping how we move forward and what we do. The pharmaceutical donations, of course, are hugely important, and how they continue, scale up, or change will impact how we implement our programs. Research continues to be one of the key motivating factors for knowing whether or not we can address specific challenges or diseases. WHO's leadership is paramount, and the development of evidence-based, realistic programs are the key to ensuring that we are able to work with countries to reach whatever goals are being set in the roadmap and beyond. Systematic engagement with cross-sector or with other sectors at the country level are becoming increasingly important, particularly in the sustainability context. And of course, there are the NGOs, which are the link between the country and policies that are being developed. I think we are a very small community. I think probably everybody in this room is not more than 1 or 2 degrees separated. But as we begin to look towards other NTDs, we will need to understand better where is the expertise and how can we leverage that. And foundational, of course, to all of this is our strong government leadership and our strategic collaboration with governments to target these diseases and achieve the objectives being laid out. So, where have we been? Where are we now, and where are we going? Is something that's very important in understanding how we can leverage our experience for the future. We don't want to just throw this all away and start something new. We want to be able to build off the foundations that we have built. As part of that, we need to continue to evolve our support as well as the innovation, much of which we've heard about this week, some of which we'll hear about today. And we will continue on the road towards 2030 for both the PC NTDs and potentially beyond that. And on a closing note, just to reiterate the importance of partnership, or sharing, as we said earlier. The collaboration between global leadership at WHO, donors, pharmaceutical companies, the NGOs, and importantly, the countries are really what drive this program. And that partnership goes all the way down, excuse me, to the individuals. Wrong button. And in that note, I want to take a moment to acknowledge the passing of a friend and colleague, Eric Mosher, who was a great collaborator and enthusiast of partnerships, and he will be missed. Thank you.
Thank you, Darren, and thank you all. This is also when we embark in a very long journey, it happened that we start, we renew, we continue, but we need to continue the work and think about those also who are here and continue the work and do it well too. We're going to take 15-minute break right now for a tea break, and we expect you to be back here at 10:30 to start with the rapid fire session. Thank you all, and see you soon. Please, your attention, please, your attention. We are about resuming. Votre attention, s'il vous plaît. Le panel, sur le panel, nous aurons des panélistes qui vont parler en anglais et d'autres qui vont parler en français. Donc, assurez-vous que vos casques sont prêts à être utilisés sur le channel approprié. We will be having a bilingual panel. Speakers will be speaking in French, others will be speaking in English. So ensure that you have the headset at the right channel based on your preference. So I would like now to introduce my colleague Achille Kabore, Technical Director and Actor to an NTD West program, who will be moderating the panel. Achille, we welcome you.
Thank you, Justin. Welcome, everyone. So the last speaker from USAID concluded on the importance of partnership. And now we have a session on partnership, progress, impact in efforts to end NTDs. And as you know, all these countries have made a lot of efforts due to the fact that they have shown leadership, but also the partners contributed. Now we are going to have a conversation, a direct conversation with the program managers. So we now have talented and experienced program managers that will help us with their experience. We need to learn, because this is a learning summit. We need to learn and adapt to our country's context and to our programs. So what we need to achieve here is to demonstrate progress towards NTD elimination goals in USAID supported countries, to underscore the partnership of USAID and NTD endemic countries and how it has contributed to progress. And then we need also to highlight the role of national leadership in recent years. I would now like to introduce our panelists. First is Dr. Fikre. He's a public health specialist with over 12 years of experience in public health, program design, implementation, and program monitoring. And is an epidemiologist by training. Is currently the Ethiopia National NTD Program Manager. He has extensive experience in leading, coordinating, and overseeing Ethiopia National NTD prevention, control, and elimination efforts. Please welcome Dr. Fikre. Our second panelist is Professor Epe from Cameroon. She's an ophthalmologist, a technical advisor for the National NTD program in Cameroon, the focal point for research. She's a full professor of epidemiology at the University of Yaoundé. Welcome, Professor Epe. And we have Dr. Joseph Opare from Ghana. He's an acting program manager for NTDs in Ghana. He's a medical officer and a consultant in public health. He has held several positions in clinical care, public health, and in the past 28 years in at the district, regional, and national level. Welcome, Dr. Opare. And then I have our dear friend from Togo, Dr. Yonsinke, who is the NTD program manager in Togo. He has expertise in skin disease. He's a dermatologist and has leadership position now. And Togo is fast moving towards elimination of NTDs, PC NTDs, and establishing a strong surveillance system to maintain the elimination of LF trachoma African human trypanosomiasis, and guinea worm disease. Welcome, Dr. Yosinke. Now I'm going to proceed with first round of questions to our panelists, and then we'll open the floor for questions, and then we'll move to the next round of questions. So first, I will go to Ethiopia. It's a large country with a lot of issues, but we know that Ethiopia has done a lot. It has faced also some unique challenges: high trachoma burden, conflict, large population, and how it has the MOH handling these challenges and has worked with donors and partners to address these challenges. Fikre.
Thanks so much, Mr. Chair, for this great opportunity. It's really a pleasure for me to speak in front of the NTD community. So, as Chair said, Ethiopia is managing a really large program for the NTDs. You know, Ethiopia is one of the top 3 NTD high burden NTD countries in sub-Saharan African countries, and we are managing a really a big number of population that require treatment and people that require case management services, including the surgery and morbidity management and so on. And this is compounded by another human-made and natural challenges like the conflict, other epidemics like COVID, and so on. So this makes really a complex environment for the NTD program in my country. So this challenge requires really building a strong and trusted partnership among different stakeholders, including governments, stakeholders, governments, states, agencies, donors, different partners, and many other stakeholders that are important stakeholders in the program. These programs and government in Ethiopia has a unique political administrative structure. With 4 levels of political administrative structure, including from the national, regional, zonal, and district. Of course, we have also common health structure, basically where the primary health care service delivery is happening. So really this service centralization and this political centralization helped us to manage all those challenges and to provide the NTD services. So on annual basis, we are treating more than 50 million treatment for glaucoma, like close to 30 million treatment for With this, we have, I can say, several of the ministries.
Professor Ebe, what is the key element of which you're proud that you would like NTD community to be aware of? And on the trajectory of your country during the last 10 years? Go ahead. Thank you, moderator, for giving me the floor, and especially for your kind words towards our country. I'm very proud to speak of Cameroon and progress achieved in the last 10 years. I will quickly speak on the coordination of NTDs that has really marked my beginning in the fight against NTDs. The fact that all NTDs are organized in an administrative manner under one regime, each following their own program according to their own strategic plan, has allowed us to bring out the issue of research. We ask ourselves, where are we going? Our objectives and our strategy lead us towards elimination. And that is how, with the support of our technical and financial partners, we have seen our capacity strengthen from the draft of the research protocol to this question. And then we were able to prepare our protocol, and then we proceeded to data collection. And here I would like to thank Tropical Data that has really supported me at each step in the research. And I'd like to remind you that I am a clinician by profession, and that I have really dabbled in health, public health. And I became an expert thanks to MTD and trachoma. And that is why my career changed pathways. Research has allowed Cameroon to move forward in the fight against MTDs, and that has brought closer all sectors, including higher education sector, because with capacity building within the programs, we have understood that alone we will not succeed. So we also went towards higher education and also basic education and even independent researchers. This means we went towards science. It was no longer education. It became public health and research in such a way. In the domain of the fight against the ANCO and against trachoma and LF, we have experts in the country that have really taken ownership of the research and the leadership. We're very proud to see that with the support of our technical and financial partners, Cameroon is able to undertake research, disseminate the results.
Quand on remarque que au niveau de notre recherche opérationnelle, de la recherche de la mise en œuvre ou de l'implémentation, nous constatons qu'on a des soucis. Nous allons remarquer
some challenges. We would like also to thank GLIDE, our partner that recently has supported us in the social science research, and that has also made us notice that we were in the process of having strategies that our community would not understand. So community engagement is now been in the middle of our fight, and we're going to adapt our strategy that is going to come out recently, that is based on the 2030 roadmap. Community engagement will be in the center. Each community will see that their program is adapted to their needs, and we commit to have indicators allowing them to understand what is happening, but also to have a better involvement and therefore better coverage that will lead us to the scaling up towards the elimination. We would also like to say that for the fight against trachoma, we also have the support of our financial technical partners, Helen Keller, USAID, that have been supported us. It's true that we've missed, we are still fighting, but we are hanging on. But with the support of our partners and the integrated fight and the integrated resources, we like to mention that our challenges do not really frighten us. And I'd like to mention Helen Keller, but she says, keep your face towards the sun and you will never see a shadow. And that is what really gives us hope. Thank you.
Merci beaucoup, professeur Epé. Vous avez fait mention de trois éléments qui sont importants.
Three things that I recall. The importance of having a strategic plan, to have data, to undertake research in order to have evidence, but also the community engagement. Thank you for having highlighted these very key issues. We'd like now to turn towards Ghana.
So Ghana is an early success story for trachoma elimination. And what are the factors that helped your program to succeed? And how you are applying the lesson learned from trachoma to reach elimination target for the other neglected tropical diseases? All right. Our story.
Okay. Hello. Yes. Thank you, Mr. Moderator, for giving us the opportunity to tell our story as to how we're able to eliminate trachoma as a disease of public health concern. You know, as far back as 1950, it was realized in Ghana that there were so many cases of blindness, and trachoma was the cause of that. So in 1988, the Ministry of Health partners did an assessment in the northern part of Ghana and realized that as many as 13,000 people suffered from trachoma plus tracheasis, right? So immediately there was partner support. Pfizer came in, managed to get us some Zithromax for us to kind of treat these people, and also some surgeries were performed. But we had to move forward, and the Ghana Trachoma Elimination Program was initiated in 2000. And the strategy here was the safe method, right? Surgery, antibiotics, facial cleanliness, and environmental improvement. These were the strategies that they used. So they continue with the search for cases and also for treatment. Then somewhere in 2007, 2008, there were assessment, right? And they realized that at least when it comes to trachomotor inflammation, there was less than 5% of cases among children 1 to 9 years. So that was a good step over here. And when WHO came out with the pre-elimination validation document, Ghana took that opportunity to assess our system to find out whether we were close by. And we realized in 2015 that we were almost there. And fortunately, in 2018, Ghana was certified to have eliminated trachoma as a disease of public health concern. So how were we able to achieve this? It was not won on a silver platter. The very first strategy was an integrated case search. You see, the focus was on trachoma. But if you go to the community to look for only trachoma, that might be a waste of what? Resources. So in addition, at looking for trachoma cases with trachomatous inflammation, tracheasis, we're also looking for guinea worm cases. We're also looking for Brody ulcer cases, so that at least if you are done with trachoma, those systems can roll over in the communities. So in addition to that, and what I can say is that with this strategy, as we speak now, Ghana is about coming out with a home-based register, okay? And this home-based register is supposed to be able to get search for cases of PC NTDs and CM NTDs. So this is what at least we learned from how we learned from the trachoma program. And also in getting trachoma out of Ghana was a house-to-house kind of search for cases. You say, if you leave it at the community level and you do not visit the individual homes, you may miss certain cases, because some cases may not come out at all. So in building upon that, Ghana is also, through the MDAs, getting cases of, let's say, lymphedema, hydroceles from the house-to-house case search. So it's just a build-up on what we got from the trachoma strategy. The other thing was on community ownership. You know, if you tell somebody that if you wash your face very well and observe some hygiene and kind of good sanitation, drink potable water, and through that you're able to get rid of trachoma, that is straightforward. So a lot of education was done in this wise for the people to understand how trachoma is spread, so that they could also get rid of this condition in the communities. So in the same vein, we are using this approach in managing the rest of the neglected tropical diseases. A lot of education is ongoing in the communities, and we are trying to send simple messages, like you want to get rid of lymphatic filariasis. What must you do? Make sure you are part of MDAs. Make sure that you sleep maybe under the treated mosquito net, so that the mosquito wouldn't bite you, because you can get the infection from there. Make sure that you are part of MDAs. You wear protective clothing when you go to farm and all that, so they can avoid these conditions. Then we also make sure that trachoma is mainstreamed in a service delivery. What does this mean? Trachoma is reported in the IDSR. Doctors, nurses are trained on how to diagnose such conditions. And when they were able to do that, they were able to detect cases and manage appropriately. So in the same vein, going back to the other neglected tropical diseases, we've managed to come up with NTD morbidity form, whereby at the end of the month, we're able to record cases of the various NTDs. LF, how many cases were suspected, how many cases of schistosomiasis were suspected, and so forth. So on that note, health workers have been trained to identify these cases, okay, at the health facility, so that we could move on. Then also you realize that after elimination of trachoma, there was a surveillance structure was put into place. Trachoma cases continue to be reported through our system, and nurses, at least in one district, in each district, somebody was trained to manage tracheasis. Someone was trained to do that, all right? And in so doing, we're able to kind of identify some cases and manage appropriately. So in the same vein, there has been a lot of capacity building in our system. And we've been doing that anytime we had review meetings, half-year review meetings, post-MDA meetings, so that at least we come up with topics and treat under neglected tropical diseases. The other thing is that we've been supported by American Leprosy Mission to incorporate in the curriculum of nurses training materials on neglected tropical diseases. We started with lymphatic filariasis. We are moving on, and we are going to have more engagements. And we know that if you're able to do that, By the time the nurse is out of school, by the time the medical officer is also out of school, at least this person has some knowledge on neglected tropical diseases. So building on coordination is very important here. There had been intense multi-sector collaboration, as our brother from Ethiopia said, internally and externally, because we could not have achieved those without partners. So internally, we have our inter-country coordinating committee where local partners are there. We think of how to move NTD activities ahead. Then externally too, we have strong partnership with the big wigs, because we have site savers supporting us so much some time ago to get rid of trachoma. We also have USAID also coming at one point to support us. So based on all these factors, we're able to get rid of trachoma in the country, and whatever we learned from the strategies in doing so, we are also incorporating some of these strategies in the delivery of services in the rest of the neglected tropical diseases. Thank you.
Thank you very much. So thank you, Dr. Upari, for highlighting two key points. First, the home-based registry. I think this is very innovative, very important, and capacity building, continuing for health workers is key. Now we are going to Togo en français. Le Togo est champion toute catégorie dans les éliminations.
With regard to elimination, we have eliminated several things and we continue to eliminate. First, the country has eliminated 4 NTDs, hepatic trypanosomiasis, African trypanosomiasis, and very recently the trachoma. According to you, what were the main pillars for this success and what were the challenges in the way forward? I thank you all. Thank you for this opportunity. Thank you, Asha, for giving me the floor. I think that it's the moment first to greet everyone, to recognize everyone. We speak of the Togo success. There are many people to recognize. The first thing is to recognize the political will in Togo. The fight against NTDs is a reality. The political will from the highest level up to the Ministry of Health, they believe strongly on elimination of NTDs. So they are taking the necessary efforts in order to arrive at this objective. And the other category to recognize here is the champions at the level of program coordinators, the visionary people who have invested a lot of their efforts in the NTDs. And today we know that they are continuing to pull Togo upwards, and this has allowed us to reach the elimination of these diseases. And the third group to recognize here is all the levels of the health pyramid, from the ministry up to what you call the CDDs at the community levels. These health workers, without them, we wouldn't be able to do anything. They go to the most remote areas, and it's because of them that we're able to reach the elimination of the diseases. So this is really the time to recognize their commitment, the community commitment, and on all the health pyramid. And the fourth group is the partners. And because of the risk of mentioning some and forgetting others, I will not list them, but I think it's important to at least mention those that come quickly in mind. And if there are those that I did not mention here, you will excuse me. We've had very various partners at USAID. All those people who, including CDC Atlanta, very early on had a lot of trust to Bill and Melinda Gates, and they were very much involved deeply in order to see the country reach the objective. I think we owe a lot to them today. And also, I cannot forget WHO in reaching elimination. The WHO, we respected the recommendations of the WHO. We followed these rules, and at the time of stage of elimination, we were ready. And so that's some of the points, but there are others, definitely. But these are some of the few points I wanted to share with you on the key success factors. You also mentioned about challenges. The first challenge is the cross-border challenge. We have eliminated, but we still have the emergence. Emerging. There are some countries that surround us have not eliminated certain diseases. So I think we need to strengthen collaboration between us and those countries that have not eliminated some of the NTDs. As you know, diseases have no boundaries. The populations migrate very easily. It's important that we work together, we collaborate together with those countries that have not eliminated. There's also the challenge of security, which is increasingly impacting the country. The north of Togo is starting to face problems. We're not able to conduct certain studies on LF, for us to make survey of LF, and we're not able to do that because of security issues. So the security issues are also affecting us. And the same for the surveillance of eliminated diseases. For us to know where we are today, with that, the country should be able to continue the surveillance on the eliminated diseases, and that is a challenge. At the time we were eliminating certain diseases, WHO did not have the directives on what to do after elimination, what next. I think that is a challenge that we need to look at and have clear directives, and so that we do not stagnate after the elimination. And the last point that I want to raise here in terms of challenge is country ownership. Togo has a sustainability plan that has been validated, signed by authorities. We should be able now to execute this sustainability plan. The different actors, stakeholders should be able to do what they are able to do, so that we do not go backwards. We have eliminated certainly, but there is still work to do. We should be able to stop the transmission. Thank you. Thank you to Togo for having lined the surveillance after elimination.
I'm now going to open the floor for any questions, so people can come here. There is a mic over here. There is another one. Okay. Any brave? Okay, Rob.
Yes, yes. My name is Rob Henry. I'm from USAID, and I just first of all want to thank the panel and the moderator. This is really a great kickoff for me to really like start to hear things, and I heard a lot immediately, and I have all. Wow, I do not always have that effect on a room. I don't know what I did, but I'm going to try not to do that again. So I have a lot of questions for everybody, but I think I'm just going to start with one and hope that other people will follow me. I think I'm directing this one mostly at Ethiopia. So I heard talk about the importance of like being able to coordinate all the partners. And as a donor, I'm very well aware that a lot of times there are a lot of partners in a country. And one thing I very much appreciate is when the country NTD program takes the leadership to actually really do that. But I can realize it can be very challenging. And I just wonder if maybe you can talk about a couple of things that you might share, having so many different partners, about how you manage to keep that together and to lead that group to help you support your program. Thank you.
So thanks so much for that excellent question, Rob. So as I said, the critical thing in partnership is having a strong and committed leadership from the government. Whatever the partner size is, if there is a strong leadership at all levels, which means from national to down to the community level, if there is a strong leadership and even commitment, political will, commitment, so there is nothing that couldn't be achieved. So as you said rightly, Rob, we have multiple partners supporting multiple entities of the program. So we are the one, it is the government of Ethiopia who is trying to manage all the stakeholders. And there should be also a mechanism where each stakeholders can meet and share lessons among themselves. So creating a conducive environment, conducive work environment is very important. So if there is a leadership, commitment and so on, everything is possible. So that's how we are striving toward this common goal. We are here to serve a work environment that can accommodate everyone in equity manner. And so, yeah, this is how we are trying. Of course, there are still many challenges because partners are supporting different programs. For example, one of the partners may support the MDA part of the trachoma, the onco, for example, and the other partner came in to support the impact survey and so on. So unless and otherwise we coordinate those two partners who are working in a single program entity, so we will, at the end, we will fail achieving our targets. So even if there are certain challenges, we are trying our best level to manage the program this way.
Any other question? Oh, okay, Lisa.
No? Yeah. Great. Thank you. Thank you to the program managers, all of you for your comments this morning and for your leadership always. I'm curious to know what, well, NTD program managers are so often technicians and not politicians. And we know the politics of achieving elimination, and to help you get visibility for your programs, additional resources is sometimes a challenge. So my question is general, but also perhaps for Togo, after having eliminated 4 NTDs, what is the what is the political climate for you? Do you get more attention because you have been so successful? Or is the change to say, well, they've finished eliminating diseases and maybe they don't need as many resources anymore? In general, how can we help you maintain visibility for NTDs? Thanks.
Okay.
That's a good question. I was actually going to come back to it. I think the problem really is the word itself, elimination. If we would find a better word, it would be much better. Each time when someone or the authority speaks about this elimination consists of this and that, even at the level of the population. And the problem is not at the political level only, but even at the lowest level, at the community level. When you speak of certain diseases today, they will tell you this is eliminated, it's finished, there is nothing more to do. And even in the conscience, the doctor who should be thinking of such issues does not also think about it anymore. When you say it's eliminated, I think this terminology, elimination, is a real problem. And I think we now find ourselves in a situation where we have more work than before. This is because we should go to explain, we should carry out more sensitization activities at all the levels, even at the highest level. That when I say highest level, even at the president level, for them, they think we've eliminated, there is nothing more to be done. So I think it's not only the ministry level, also the partner level. We do have this difficulty in carrying out advocacy for a disease that has already been eliminated. So I think for this aspect, we should take this up. And I said, I spoke about surveillance, the possibility of the resurgence of the disease, because around us we do have countries, etc. And so the advocacy has to continue in all the levels, and in supporting sensitization, this has to continue in all the levels. Thank you. There is no sound.
Adequately resourced. There's an assumption that coordination, multi-sectoral coordination for F&E comes naturally for a program manager. There isn't any training. The issue is you go ahead and coordinate and collaborate. There is not a how-to. There's an assumption that this comes automatically. What is your current experience and what are the challenges that you're facing with coordinating across multiple government and non-government sectors? Thank you.
Okay, I think we have two eliminators, Ghana and Togo. Maybe Dr. Opari, you don't want to talk about trachoma elimination?
Well, when it comes to the post-elimination surveillance, that is where we have a little bit of a challenge. Because you remember, before we got to that level, health workers were trained, at least in each district, we had somebody trained to manage tracheasis and trachomatous inflammation and all that. And we had many health workers trained to identify the cases at the OPDs, and also volunteers trained to refer cases to the health facilities and so forth. So afterwards, much of the activity on trachoma had been given to the eye care unit of the Ministry of Health. All right. So they do most of these cases. But in our instance, we are also monitoring the cases from our district health management information systems. So we've not seen so many cases per se, but we are still doing that monitoring aspect. And we are also looking for some support to make sure that we train new caliber of health workers to be able to diagnose and detect cases, and also make sure that we have the community volunteers also trained. So this is the step that we've got into to make sure that we don't miss any case in the communities. Thank you. I don't know whether.
Dr. Yusinkiu, vous voulez?
Okay. I think 2 or 3 minutes left. Maybe we can save time for the next session. I would like to have a round of applause for our panelists. Merci beaucoup.
Thank you. Thank you very much. Thank you very much.
Achille, thank you for really the time you took.
Merci, Achille, pour le temps que vous avez.
Thank you also for bringing some new words in the NTD lexical with term of eliminator, champion to category. And thanks also to the panelists. We are going to move to some of the aspects we mentioned here. I heard Darren talking about 6-7 million people treated, billion of treatment. The panelists talk about health workers that support the field activity. And we are right now going to share with you a video entitled, it's called More Than Medicine, Nepal Journey to Eliminate a Disease and Follow a Health Workers as she worked to educate her community about lymphatic. This video is from Act 2 and NTD East program, and it's going to show us what happened really on the field. We sometimes, when we talk about elimination, we talk about treatment, we don't see people moving under the sun, moving when it's raining to get to the community, coming back because people are not at home, and combining all this work with their own household work. So we're following today a real case and how it happened on the field. Please, mighty team, we listen to you.
हात्तीपाइले रोग विरुद्ध आम औषधि सेवन कार्यक्रम सम्बन्धी अत्यन्त जरुरी सूचना।
यो औषधिले हाम्रो शरीरमा हात्तीपाइलेको परजीवी भए नष्ट गर्नुका साथै हात्तीपाइले हुनबाट पनि बचाउँछ। हात्तीपाइले रोग निवारण अभियानमा
रोग निवारण गर्ने कुरा चान्चुने होइन र यो औषधि खुवाउनु मात्र पनि ठूलो कुरा होइन। मेरो नाम पुष्पा देवी अधिकारी हो र म स्वास्थ्यकर्मी हुँ। नेपालका धेरै समुदायहरू भौगोलिक रूपमा पुग्नको लागि एकदमै कठिन छन्। नेपाल सरकारले हात्तीपाइले जस्तो डरलाग्दो र अपाङ्गता बनाउने रोगलाई समुदायसँग मिलेर निवारण गर्ने लक्ष्य राखेको छ। फाइलेरियासिस रोग जसलाई हात्तीपाइले पनि भनिन्छ र यो रोग लामखुट्टेको टोकाइबाट सर्दछ। यसले मानिसको विभिन्न अङ्गहरू सुन्निने र फुल्ने हुन्छ। यो रोग लागिसकेपछि पूर्ण रूपमा उपचार हुँदैन। हामी हाम्रो समुदायका सम्पूर्ण व्यक्तिहरूलाई 14 दिन लगाएर औषधि खुवाउँछौँ। पहिलो दिन धेरै जस्तो मानिसहरू औषधि खान बुथमा आउनुहुन्छ र दोस्रो दिनदेखि हामी घर भेटमा गएर खुवाउँछौँ।
मलाई पुरानो लुगा बनाइदिन एकदमै मन पर्छ। मान्छेले त्यसलाई फाल्नुभन्दा रिपेयर गरेर लगाएको राम्रो हुन्छ। म सधैँ बिहानदेखि बेलुकासम्म काम गरेर मेरो बालबच्चा पालिराखेको छु। मेरो नाम चन्द्रबहादुर परियार हो। म सिलाइ काम गर्छु। म मेरो परिवार र बच्चाहरूसँग बस्छु। स्वास्थ्य कर्मीहरू घरमा आउँदा औषधि मैले खाना मान्दिनँ थिएँ। मलाई केही भएको छैन, म स्वस्थ छु, मलाई औषधि किन चाहियो भन्ने सोचेको थिएँ।
कोही मानिसहरूले कहिले पनि औषधि खाएको हुँदैनन् र कोही मानिसहरूले खान नमान्ने पनि हुन्छन्। त्यस्ता मानिसहरूलाई सम्झाइ बुझाइ औषधि खुवाउनु पर्ने पनि मेरो काम हो। म उनीहरूलाई यस औषधिले कुनै पनि असर गर्दैन र यो हात्तीपाइले रोगबाट बचाउँछ भनेर सम्झाउँछु।
स्वास्थ्य कर्मीले मलाई औषधि नखाएपछि पछि बिरामी पर्नुहुन्छ भन्नुभयो। म आफू र मेरो परिवार र यो गाउँ समुदायलाई यो रोग नलागोस् भनेर हात्तीपाइलेको औषधि मैले प्रयोग गरेँ। म काम गरेर खानुपर्ने मान्छे, बच्चा बच्ची हुर्काउँछ।
मैले जे गरिरहेको छु त्यसमा मैले गर्व गर्दछु र हामी नेपालबाट हात्तीपाइले रोग निवारणको धेरै नजिक पुगिसकेका छौँ।
Thank you for reacting so promptly and acknowledging the effort and of what we have seen here, but also those who work it on creating this video and this message, which is part of also a broader strategy to highlight effort around getting the drugs to people. But beyond the drugs, I think there's a lot of message around how also to communicate and sensitize people about why they are doing this and why also it's important for the community. We're going now to move to next stage, which is about talking about some of the technical things through a rapid fire session. We'll have a series of experts sharing some thoughts on a specific topics, and I would like to welcome those who will be presenting to join the podium, starting with Mike French. Mike, I would like to welcome you to the stage. Oh, okay. So all rapid fire session speakers, please join us. Anna will be with us. Dr. Mensa Ernest, Jeremiah, Professor Epe, Upengo, Ashil. We have several chairs. Okay. So we have 7 rapid fire session. After that, we will take some time for a Q&A. So if you have questions, please write it down. And we'll be using the 2 microphones for the Q&A. I would like to hand over to Mike French, for the first presentation.
Thank you. Good morning, all. My name is Mike French. I'm from the ACT East program. And actually, I'm going to be presenting some work that also includes examples from our colleagues in ACT West and also core NTDs, which you may have heard briefly when Darren was talking. So we know that USAID have been supporting global programs against neglected tropical diseases for 15 years. In that time, they and their partners have tried many innovative approaches to reach elimination. Often those approaches work, sometimes they don't. So we're going to spend the next 4 minutes and 28 seconds exploring 5 of those which didn't work and what was learned from them. The first example of failure is unfocused social mobilization messages. More posters don't equal more people. We know that when we're trying to reach these populations, I'm sure everyone has felt in the past, maybe if we just have a few more posters, a few more radio messages, a few more banners, we're going to reach those populations. But if those messages aren't targeted at the populations that aren't receiving treatment, then more of the same is not going to be the answer. And I'd like to call out an example of a country that has really took that challenge on and challenged the assumptions about reaching the right populations, and that was Haiti, who did it in a very deliberative, very intentional way in 2021 in their data forward approach. And the outcomes of that were they really needed to target the message, not only the messages, are incredibly important. They build momentum, they create partnerships, but it's very easy for that momentum to slip away if you don't follow it up by going exactly where you need to for the work. And over time, we've come to realize the importance of local and even hyper-local coordination to understand the specific barriers, the specific challenges, the social and political dynamics of an area. And actually, later on in this session or the next session, we're going to hear some examples of that in the cross-border work in Karamoja, in Uganda, and also in the Maasai populations in Tanzania. And this will become an even bigger issue as countries are left with the most challenging areas. So second failure, or second message is get out of the capital. The third failure is technology doesn't always make things easier, regardless of what we would like to believe. There are many challenges with standardizing the results from rapid diagnostic tests. Can be reader fatigue, can be bad light, bad eyesight, poor network coverage, and a mobile reader can help to standardize those. Here's an example where it didn't. This is the M reader for filariasis test strips for lymphatic filariasis. This example is from our colleagues at Core NTD. It made sense in principle, but in practice, it was fiddly. You needed to cut the sample pads. It increased blood contamination. This is not to say that these readers won't work in other areas in the future, but I think the take-home message here is review early, fail early if you have to, and move on. The fourth example of failure is thinking about MMDP too late. And I think this is really key because we've been hearing lots of examples about this over the last 3 days. We know elimination can seem like a really long time in the future, but it's never too early to start identifying the data and also identifying the data you don't have. We know that morbidity assessments are required for elimination of lymphatic filariasis and trachoma. And the response to this is, and this is an example from our colleagues in ACT West, adding MMDP collection to MDA platforms, which has been done in Cameroon, Benin, Cote d'Ivoire, Senegal, I think some more countries as well. And also following that up by developing MMDP strategic plans, seeing how MMDP can be added into national health insurance as well.
Dans la couverture santé nationale. Cinquièmement,
This is painful for many of us because we are very quantitative based. If we can't count it, it doesn't exist, has been my mantra. And quantitative data provides a huge amount of useful information of the mapping, the coverage, et cetera, But as we get to these really tough last mile challenges, if we don't have a super rich data set to really understand the specific challenges in that area, then we're never going to get over the last mile. And the example I would give here of where it's now working is adding knowledge, attitudes, and practices surveys to coverage evaluation surveys, thinking about key informant interviews, focus group discussions, ripple effects mapping. It's required us to learn new tools and a new language as well for some of us. So that is the fifth and final one. Sorry, we could only do 5. I'm sure many of you have other fabulous favorite failures that you would like to mention. So please do come and find me afterwards to discuss failure. Thank you to Act East and in particular Act West, core NTDs, and of course the Ministries of Health. Thank you.
Thank you. My name is Jeremiah Ngondi. I'm actually the trachoma focal point for Act East. And today I'm going to talk about tricky trachoma, but more importantly, focusing on how the USAID program is leading innovation, learning, and adaptation to address persistent and recruitant active trachoma. We heard from Darren that 19 countries are supported by USAID for trachoma control. We've had good progress. Slightly over that have actually been validated for elimination of trachoma as a public health problem. However, persistent recruitant trachoma is a growing endgame challenge. It's not a new problem. Within the USAID program, we've known about this since 2018 because we routinely look at data to understand trends and how to run programs better. So we noticed at that point that there was an increasing proportion of surveys which were above the elimination threshold year on year. In 2020 and 2022, we brought this issue to the core NTD to distill operational research priorities on how to do things better to tackle the endgame challenges. Then in 2021, WHO convened an informal consultation to look at endgame challenges on this particular problem. And indeed, USAID contributed these conversations by bringing on board lessons that we had learned from the portfolio. What's the scope of the problem? Presently, there is about 350 evaluation units globally, which are either persistent or recruitant. But the big picture here is that USAID portfolio contributes to over a quarter of these evaluation units. This is a growing problem. Therefore, it's urgent that we innovate, we learn, we adapt so as we can do things differently and really get rid of this challenge so that countries can attain elimination in a timely manner. Now, what have we done broadly about this problem? Going back to the 2018 challenge, we put together a technical brief which helped the portfolio to come up with a way of doing investigations for all surveys that are a TF above elimination threshold. And really this helped to distill the data as well as provide evidence for MDA improvement, which was context specific because really each district has got a unique challenge. But then building on those lessons that we've learned from the DSA investigations, we've taken on board the new strategies which have been proposed by the WHO informal consultation around MDA, modified MDA, which looks at increasing the MDA pressure either by having more annual rounds or having more frequent than annual rounds. For example, by annual MDA within a year. But not just about throwing more drugs into the problem. We are also using coverage evaluation surveys to understand, for example, where we are doing biannual MDA, who's treated once, who's treated twice, and who's not being treated. The other important thing that we are taking on board is incorporating testing of ocular chlamydia infection and serology into the routine trachoma impact and surveillance survey. Already we've had a very successful pilot of this approach in Mozambique in 2022 with very, very good results, which showed us that this can be done effectively and really And in the coming year, we're expanding this into more countries. Indeed, my counterpart from Cameroon is going to be talking about some of the strategies that they're bringing on board to tackle this particular problem in Cameroon. But do remember that this is a well thought out approach, which is a continuous learning and adaptation. So as we get more learning from the modified MDA and from the TIS plus and the TSS plus, this will then feed into the continuous learning and adaptation. Now, broadly, high baseline TF prevalence, mobile migrant population, and low coverage with WASH are some of the drivers that are driving persistent trachoma. Currently, there are zithromax shortage issues, and we are working closely with the ITI to see how best we can serve these populations so that they are not left behind. But the other important thing is also to remember that we've got two critical criteria for elimination of trachoma, one which is on TF, the second one is on trichiasis. So we also need to make sure that the MMDP component is not left behind so that countries can attain elimination in a timely manner. Going forward, the innovation, learning, and adaptation for optimal MDA coverage is going to be very, very important. Scaling up the persistent recruitment strategies is going to be important. And also we need to think beyond elimination and make sure that we are thinking about the surveillance systems that are required for us to be able to secure the gains that we are making by investing time, resources into this particular process. Thank you.
Good morning again. My name is Emilienne Epe from Cameroon, and I'm going to talk about the challenges of the program in Cameroon. Okay. The history of trachoma in Cameroon started with an alert in Kolofata in 2006, and this led to investigations, mapping of trachoma, first in Kolofata, then in the northern with 21 district endemics concentrated in two regions, the north and the far north. From 2010 to 2018, the SAFE strategy was implemented in those health districts according to the high endemicity. MGA and T surveys were validated with TF less than 5% for the under 1 to 9 years old. As the results of that, MGA stopped following WHO recommendations. In 2019, surveillance survey carried out revealed that 19 out of the 21 health districts within the journey passed the survey, but we were surprised with 2 health districts that failed the surveillance survey. And this was unexpected, and it marked the challenges of our journey towards elimination. Golfe, as shown on the picture, Makari later on split into Makari and Fotokol health districts in the far north were in recrudescence. On the other hand, we had Kolofata, where we had to redo the mapping, and the results were that in 2013 and 2022, the 2 surveys revealed TF above 5%. And the interventions were delayed in Kolofata because of insecurity in the area. In order to understand what was going on, we were looking for the possible causes of the failure. The national program carried out operational survey to validate the investigations, to validate and investigate the reasons for persistence and recrudescence at all levels of implementation. In-depth review and investigation in Golfe, Makari, and Fotokol were then planned and organized to assess the effectiveness of evidence-based programmatic adaptation, evaluation coverage of mass drug administration, and of the concerned health districts. Specifically, we were looking at the sociocultural and behavioral factors associated with high TF prevalence that could inform more effective program intervention in Golfe, Makari, Fotokol, and Kolofata. The preliminary results highlighted that at the level of WASH, water scarcity and poor maintenance of water works, as well as lack of coordination in activities between the stakeholders, was a problem. And our solution, our proposed solution, is that a coordinated task force is needed, as the MOH cannot solve the problem alone. When we discuss about transition, we noticed that there's a low and insufficient awareness of the population and on risk behavior and preventive measures of the disease, leading to continuous cohabitation with animals and persistent promiscuity that remain common. So monitoring behavior changes with integration with other health programs must be effective, and mobilization of internal resources, as a matter of fact, because the national program is highly dependent on resource mobilized by NGOs. When we assess the trans-borders issues, we notice the movements between the populations that accentuated the human-to-human transition. So pursuing, on the second hand, pursuing activities in insecure area was difficult. The surveillance survey too was not put in place while between the two surveys, TIS and the surveillance survey. So our solution is that the program should include strategies for elimination in between the surveys. In summary, surveillance surveys is important, is an important criterion, but it's not enough when we talk about post validation of TIS. The FNE activity should be continuous, as well as information, education, and communication. The strategies for population movement and mixed interaction during the control phase are important and should be described in trans-borders activities elimination. So what are our next steps? Ongoing research is important. We are trying to look at the dynamics of the seroprevalence, trans-border meeting, and in fact, Chad, Nigeria, DRC, and Niger are invited to joint activities in the coming RAFET in October 2023. We also need to improve in the WASH activities and plan for surveillance. I thank you for your kind attention.
My name is Ernest Mensah. I'm the LF focal point for Act to End NTD West program. I am presenting an idea of when to do confirmatory mapping, why you need to do it, and how soon you should do it. Now, for lymphatic filariasis elimination, everything starts with mapping. You have at least 5 years of treatment. Then you have to do a pre-TAS and a TAS. If you are successful at a TAS, you have at least 4 years for post-treatment surveillance to complete TAS 3. Then you have your dossier to do. That gives you at least 10 years. Now, can you imagine that you get to 10 years and you are almost done past your last TAS 3? Then you find out that 2 or 3 districts that are considered non-endemic are actually endemic. You know the feeling? It will be like getting to a marathon, get to the finish line, and you are told that, I'm sorry, the finish line moved. By how much? 42 kilometers, another 10 years. So you don't want to have that. Now, the challenge we had was that in a few of our countries, they reported areas where they thought the endemicity was uncertain. These were places that have already been designated as non-endemic. And their reasons was that some of them, the mapping that was done could be questioned, because at the time of mapping, they thought that there wasn't enough risk factors to consider them as endemic. For others, because of having similar geography as others that have been mapped as non-endemic, they were considered non-endemic. And then in reviewing the data, we found out that the mapping protocol, some of them had gaps. Not the number of samples that were expected were not taken into consideration. So, and for other places, they were reporting too many positive cases for places that are considered as non-endemic. So what do? We decided to review the mapping data and the mapping methods for all the countries that had non-endemic district. And there were 7 of them in the Act West portfolio: Senegal, Guinea, Ivory Coast, Ghana, Benin, Niger, and Cameroon. What did we find? We found out there were 38 districts that had reasonable cost for remapping, and 3 each in Niger, Cote d'Ivoire, and 4 in Guinea. Now, after we found this, we presented it to experts for their comments, and the experts thought that there was good enough reason. Some of them shared boundaries with areas that were persistently having transmission. And therefore, we went ahead to do confirmatory mapping using the WHO mini-task protocol, which is considered more rigorous. We found 2 districts to be endemic in Ghana. For the others, none of them. For Ghana, it means that their anticipated elimination date has moved 5 years on. That takes them beyond the 2030 WHO expectation. So it is important to make sure that confirmatory mapping is done as early as possible if there is a cost to have it done. Now, for next steps or the learnings that we have from this, it is important to reassess areas if there is enough concern that these areas may be endemic, although they have been designated as non-endemic. And then you must seek expert advice and confirm the status of endemicity as soon as possible. However, we also found out from the data that you saw that it is not reasonable or there's no merit in remapping all non-endemic areas. Thank you very much for listening.
Good morning. I think it's still morning, yes? Yeah. Okay, yeah, my name is Upendo Mwingira. I'm the Technical Director of the USAID Act and NTD East program. This presentation I'm going to be giving with my colleague, Dr. Ashil Kabore, also the Technical Director from Act NTD West. We are here to share with you the decades of Nkosekasi's progress, the key impact and challenges. Sorry, I didn't know that I have this one. Yeah. Okay. Yeah, we've seen a lot of progress. This chart here shows the achievements or kind of the progress of onco elimination in the countries we are supporting. As you can see, we are not in the green, all of us, all the countries, but we are there. We are many in the light green place, whereby many countries have been able to stop Onchocerciasis MDA in at least one of the 4 sites. And this is a very, very great progress. I think you can agree with me, those in onco community, that Onchocerciasis is a program whereby a child can be born and be 20 years old and it's still there. So it's completely different from other NTDs. We are still having some countries like Mozambique whereby a lot is needed to be done. We need to celebrate these challenges. As I've said before, we are not there yet to announce many countries being eliminated the disease, but we need to appreciate the milestones the countries have made, as I've shown in the previous slide. We are also seeing, we are expecting to have Niger being confirmed and verified, kind of announced. The dossier has been submitted, but the announcement is yet to be done, but we are expecting it to be very, very soon. And this is the first country in Africa to be submitting the dossier and expected to be declaring elimination. Can we clap for Niger, please? Yeah, we are seeing a lot of achievements in Togo, Senegal, and Nigeria. Several districts, millions of people are now no longer need MDA, and this is a great success. As I said, a lot of investment has been done over years, so we really need to celebrate. We are also seeing many countries now coming to Stop MDA. We are expecting to support Stop MDA surveys in around 68 districts in next year, and more to come. Uganda, my neighbor, is very close. Please clap for them. They are really, they have 17 foresight, and 15 out of them have stopped MDA. So only 2 have remained, and most of them are just because they are within the borders. So please clap for Uganda. We are now, with the USAID investment, targeting hypoendemic areas. And this is very plus. We didn't used to do this before, but we are now targeting hypoendemic areas like Mozambique. They were used to be hypoendemic, but now we are supporting them. We have challenges. Yes, we have clapped so much, but we have challenges. I think all of us can agree that we are really frustrated with oncodiagnostics. This is a great challenge. There's a lot of limitations with rapid diagnostic tests. We have inconclusive ELISA results. The lab capacity in our countries is not as good as we are thinking, as we want it to be. The logistics of getting reagents in the countries, those are some of the global challenges we are getting. All countries are experiencing that. But in our countries, we are seeing that there is a challenge of co-endemicity with loasis. Cameroon is one of them, the risk of side effects. But we are also struggling with also refining or defining endemicity in some of the areas. So my colleague Ashil will come here and get down to all those, at least key of those challenges that we are facing. Thank you very much.
Thank you, Upendo. Indeed, we have challenges, and we'd like to talk about one of the challenges we have seen in Tanzania is how to define endemicity and impact of MDA. We have these 4 districts that are bordering onco districts, but we are also LF endemic and in post-MDA surveillance. There is a need to be flexible and also take into account the local context in defining endemicity. The National Onchocerciasis Elimination Committee has recommended a stepwise approach to resolve the problem. So first, the desk review concluded that these places are really indicative of, suitable for onco transmission. We have this onco elimination mapping in the 4 districts that held a threshold that is below the MDA threshold, but they are clustering, and using this onco RD test show that there are some issues of clustering of positives. So the survey in the children that were the unit, the implementation unit was split into 2 evaluation units, 3,000 children in each, and concluded that these are above 0.1%. And then actually there is no need to go for MDA in these districts. In Togo, we saw something that was unexpected. When we did the Stop MDA in the maritime region, that is the transmission zone, the Apangaji is an area where they recorded slightly above the threshold. And that was unexpected because all the other areas were negative, 0% for the AP and the entomology. So what the NOC decided is to re-examine and analyze this zone, because it actually is a border, it's close to Benin. So they need to have a high resolution map of the river basin. The blackfly breeding sites have to be mapped properly. We need to review a granular implementation when the MDA happened and the MDA data needed to review. And then we looked at the history of a control elimination in this area of Afringaji, and then how the challenge was addressed. In the maritime region, they stopped MDA, except in this sub-focus, because it's now like a hotspot in the area. So, but the decision is to continue treating, but also doing annual investigation, entomology and epidemiology, and report back to the NOC. And then the last epi and entomology will be considered as a stop MDA in the Afringaji sub-focus. So this was really an important step to look at how the granular data in this area is very useful, but the other element that was added to that is to see what is happening in the border with Benin, to look at how this could be coordinated in terms of efforts to make sure there is no issue in terms of transmission between Benin and Togo. So this is a picture that we were in February in Niger, when the dossier was submitted officially to WHO, so by the Minister of Health. And then we think that despite all the challenges and the long time frame for onchocerciasis, 12 and 15 years of elimination, we need to celebrate, and we need to continue supporting, strengthening data, looking at the capacity or in data, in onco data collection, analysis, and decision-making, but also increase partnership and harmonization on oncodiagnostic protocol in countries and beyond to overcome the challenges. This has been said because we know that partnership is not only important to when we are doing this type of analysis, but also moving forward, we needed to make sure we have the NOC leading the countries and have this ownership for onco elimination. So I would like to acknowledge all the NTD program managers, Act East and Act West, for the dedication, commitment in supporting onco elimination efforts. Thank you.
Hi, my name is Anna Phillips. I'm the learning lead and Schisto and STH focal point for Act West. And I'm going to be talking about what's the deal with deworming. So I just want to touch on Ernest's analogy to the marathon. When Paul presented the M&E framework for Schisto and STH on Monday, and he said they're not touching on stopping Schisto treatment, I thought, oh boy, we have to be ultra marathon runners in Schisto. So the background in Schisto. So there is, the recommendations is to reevaluate after 5 rounds of treatment. And on top of that, there is an increasing push to shift from district to sub-district implementation. But there currently isn't a protocol on how to do those impact assessment and the evaluations. So in Act West, we developed a protocol in 2020, and this was based on an evaluation, a paper that Sarah Knowles published in 2017, which was really an excellent paper, if anyone's interested in schisto sampling, but she looked at various countries and evaluated how many schools should be assessed per district and how many children per school to actually give an accurate estimate of district prevalence. And the results show that there really were diminishing returns when you increase the number of school children sampled in each school, but you really did need to sample more than 5 schools per district. So off the back of this, we developed this assessment protocol in 2020, and we took the recommendations of the paper, which said 15 schools per district, which estimated out around 1 to 5 schools per sub-district, depending on the size, with a random selection of 24 children per school. And the purpose of this impact protocol was not only to evaluate the impact of treatment, but also determine sub-district prevalence. So this protocol was rolled out across 7 countries in the Act West portfolio, of which 4 of these countries are here today. We have Benin and Senegal and Togo and Ghana, all of which have done this, and Burkina Faso, Mali, and Sierra Leone, who are not here. So I'm just going to give an example of the schistosomiasis map that came off one of these countries in Sierra Leone. So we created district prevalence maps and sub-district prevalence maps. And you can see that when we look at the sub-district, we really start picking up on those hotspot, high prevalence areas. And you would miss those nuances if we're just looking at the district level. Now, the Task Force for Global Health in 2022 launched the schistosomiasis oversampling study. And these 4 countries implemented this survey, all of which were in Act West, Cote d'Ivoire, Ghana, Togo, and Mali. And they came out with some really great recommendations, some interim recommendations. And that was that there will be homogeneous low areas. There will be homogeneous high areas. And in those circumstances, given the investment in logistics and time and money, we probably don't need to go back to those areas. And actually, because they're homogeneous across the district, that's probably a sufficient amount of information. However, there are areas that are more heterogeneous, and you will pick up on those hotspots. And it's really in those areas that it's warranted to put that investment to going back into there. Another strategy that has also been touched on by various groups is geospatial risk mapping. So we also created a geospatial risk map for the countries that have done these surveys. And again, this is an example from Sierra Leone, where you can take into account distance to water, climate, altitude. And again, you can start picking up on those more high intensity areas, those with the higher force of infection, to really start prioritizing going back to those areas. So when there is this push to go to sub-district treatment, the reality is there are many countries that have hundreds of sub-districts that just don't have any data whatsoever. So these geospatial risk maps can really be helpful in starting to prioritize that. So what do we do with these data when we would do the surveys? We've been developing a roadmap for countries to start coming up with a treatment strategy, and also prioritizing areas of these assessments. So yes, the future of schisto is focalized treatment, but there are gaps that need to be done to inform those. But as I said, there are strategies to tackle that. Act East and West developed a tracker in which all of these data have gone in, and this helps provide an evidence base to make treatment decisions at the sub-district level. I'll finish because I've got the sign up, so I'm going to stop now.
Thank you, Anna. And thank you all for also sharing so thoughtful insight with the audience. We're going to take 2 questions. We'll be using the 2 microphones to allow those who are online to hear questions. Yes, introduce yourself, and someone get ready for the second question on the right side, the left side.
Hello, Paul Emerson. Today I'm wearing my International Trachoma Initiative hat. Firstly, I should say thank you very much to USAID and RTI, who and FHI actually, who are the single largest distributor of Zithromax donated for the Global Trachoma Program. So thank you, USAID. Thank you, RTI. Jeremiah, with the Zithromax shortage that you alluded to, this year, 2022, we've only been able to ship 80% of the approved drug. How has the coverage been affected in your areas where you've done your TIS plus? Do you have data for coverage for 2022?
Thank you, Paul, for that important question. And one of the things we've taken on board with the Zithromax shortage really is going back to the learning and adaptation. Within the portfolio, we've developed a strategy which is very country specific, but also broadly in terms of how to mitigate Zithromax shortage. But also some of the decisions which are being made on where to allocate the Zithromax based on the guidance from ITI are really with the ministries themselves. And that's where we sit as a team to really look at the epidemiology and the prioritization of how the available drug is going to be done. And I'll give you the example of Uganda, which has been one of the very first countries to do this, the MDA following the reduction of allocation to 80%. So in Uganda, we've got 5 districts that are currently endemic. They are all either recruitant or persistent. So when we look at all the prioritization criteria, there isn't any place we can say that this is going to be left behind, not treated for now. They all are priority. But then with the Uganda MOH, we came up with an approach whereby we were going to do things much more smartly in terms of doing the MDA. And we went back to the drawing board, said that, okay, we've got 80% allocation. The WHO recommendation is to have at least 80% of the population reached with the drugs. Therefore, how could we use allocation to make sure that the drugs end up in people's mouths rather than in warehouses or some out of the field health facilities? So the trick was to come up with a near real-time reverse logistics, whereby once a CDD finished their portion of the MDA, they gave back the forms and the drug that was left over. And therefore it was possible to redistribute the drug within the districts and also outside the districts to be able to undertake, to make shortfalls for any place where there was a shortage. And surprisingly, because of this improved, more like real-time supervision and support for these CDDs, we are seeing the best ever MDA coverage in places like Moroto in Uganda, where we've actually, for a long time, never been able to go above 80%. And for the first time, with less drug, we're able to be smart and have the resources to be able to make sure that the drug is covering 80% of the population. Now, the other thing is that we are not stopping there. It's also the learning that comes out of this. So we're going to be doing coverage of your service to then go back and check who was treated, who was not treated. Part of the whole process is to make sure that the groups that are at high risk of trachoma, which is really the children and their caregivers, are receiving Zithromax. So looking at the coverage of regional data, we're going to have a better understanding of how this is working. Thank you.
A second and last question from the audience. Oh, you asked it question this morning. Let's. Okay, please. Introduce yourself again.
Finally. Thank you. I'm Baina Gilbert. I'm from the Federalist Foundation. I deal with trachoma. So when I stand here, it's mainly trachoma. Again, wonderful panel, and thank you so much for the insights. Very interesting. My question goes to case definitions. The surveillance systems in countries depend on case definitions and the ability of the system to detect and diagnose a particular condition before you can report it. In the current situation, we have experimented with sentinel sites. We have pushed very much for inclusion of trachoma indicators in the DHIS2. Other methods, including facility-based diagnosis, have been piloted. Now, back to Jeremiah. Do we have any proof of concept on which is sustainable, which is practical, and which the countries can sustain over a period? Because each one has its pitfalls, its difficulties in implementation, and its cost implications. Thank you.
Seems like trachoma is getting a lot of attention. Gilbert, you bring an important aspect, and as highlighted as well as Professor Epe, that understanding the disease dynamics before elimination and after elimination is going to be important. And what you are saying sounds like what Ernest was saying, that let's wait until the end, then we start thinking about surveillance. I think we should have started thinking about that particular component right at the beginning. But there are two moving bits. There's the health system bit, and then there's the technical bit. And we are at a watershed moment where those two systems need to talk to each other, so that we, the technical people, we come up with the magic bullet, which there's gonna be none in terms of how to diagnose trachoma, or a range of options that can be used within the routine system. And I think it's very, very exciting to see that we've got now NTD indicators within the DHIS too. The next point really is then to go back to the drawing board, start teaching those healthcare workers on how to diagnose trachoma using the WHO simplified grading system. Part of what USAID has actually supported recently is the tropical data framework that's now moving from field-based to photo-based training. And I think this could be a good opportunity for expanding into those health facility level surveillance components, so that then when those numbers are put in the system, then we've got a clear understanding as to what they mean. Thank you.
Yes, let's clap for this. And let's clap for trachoma people. Let's clap for Onco. Shisto. The race, marathon, guys, LF. And let's clap for all NTDs. And let's clap for us. Yeah. Thank you. And I know many of you have questions, but we'll have opportunity to interact with panelists during the break. We have time constraint. I also have a question, but I'm going to ask them later. But one thing which is really something that retained my attention from the first panel going through the second panel is some complexity we are seeing. Dr. Nyosike mentioned the cross-border issue, security, extra. Jeremiah started talking about persistence. Professor Epe saying that, okay, there is persistence, but there is recrudescence, there is border security, etc. But at the end, she said, MOH cannot do it alone. So expecting that Emily Winrad will follow Rob and ask question, because we are getting into very complex problems that require a way of doing a system approach. And thank you, Jeremiah, for mentioning this, that different pieces need to talk together, and we need to look at all these things in a system way of doing, in a system approach. Let's close this morning session with also thinking about how we operate in a way that we look at different pieces, we look at cross-sector collaboration, we look at also how best to leverage different components of the system to address some of this very technical, but also political related issue we are facing right now as we move forward towards the elimination. So I'm going to invite all of you to join those who are in the panel for the group photo. Group photo, no ticket for lunch. So that's group photo. Please join us. Should we move the chair?
Yeah. So we're just going to move the furniture from the stage. If you're particularly tall, please can you come to the back of the stage? And if you're less tall, if you wouldn't mind coming to the front. If you can see, there's two big pillars at the front here. We need everybody inside the pillars. And our photographer is going to take a lovely photo. Thank you. Please don't be shy. Come onto the stage. Thank you.
Hello, hello. Yeah, now it's working.
So people are outside of the pillars. You're not going to be in the photo. So we need you to come forward into the middle, please. That's it. Lovely. Janine, you're perfect. Everyone turn to your neighbor and make friends. We're just getting some light. Okay. Oh, apparently you're not happy enough. Can we have the photographer taking photos? Or? Sorry, I'm not sure what's happening. Oh, it's the lighting. Beautiful. It's going to be the best photo. Oh, I'm not in it. Move.
So cool. Everyone's doing a great job.
Yeah. Oh, look at that.
Oh, put your head.
Okay, everybody smile. Yeah, we're ready. Everyone say cheese. Cheese.
Okay. I was going to.
Should we have a little cheer one? Yay. Yay. Woo. Put the hands in the air. Yay. Are we good? Did we get a good one? I think it's too late. Lunch is in the Kili Marquee, which is downstairs. It's through the cafe, over the bridge and into the marquee. And please be back here.
Okay, good afternoon. I don't think we will be as eloquent as Justin. I don't know if Jesse, you've prepared any joke or tips because people are coming from lunch.
Oh,
Je
no.
pense que vous avez préparé quelques plaisanteries, quelques blagues. Comme les gens reviennent de la pause déjeuner.
But I can jot something down real quick.
Okay, no problem. But for sure, we won't be eloquent, but for sure, we will not be funny. This will be a very serious session. Noted?
Noted.
Thank you.
Welcome back, everybody. I hope you enjoyed your lunch. For those who don't know me, I am Wangeshi Thua, or just Geshi, and I'm with USAID's ACT East program.
Thank you, Geshi. Good afternoon. My name is Mao Fal from RTI International. I'm the chief of party of the Project ACT East based in Mozambique. So we are now going to jump into our second round of rapid fire. I'm going to ask, please, the speaker to join me at the stage. We are going to discuss about innovation, about approach, about proposition. How can we do things new? How can you do things better? You know, to face challenges that permits during delivery of NTD services. So I'm asking, please, Sharon and all the speakers to join me in the podium, in the stage. Sharon, don't be shy, please. You can come. So we have a fabulous group of speakers. And first up, I'm going to ask Sharon to come. Sharon is the chief of party of ACT East. She's based in Uganda. Sharon, please.
Thank you, Bawa. Hi, everyone. I hope you had a good lunch, and I hope we're ready for this next session. As Mawa said, I'm Sharon. I'm the chief of party for ACT East. ACT East in Uganda. And today I'm talking about something that I'm really passionate about and absolutely love, and that's the must reach in Karamoja strategies for reaching key populations. So travel with me to Karamoja, Uganda. It's an area along the border with Kenya and home to the Karamojong and other nomadic pastoralist groups who move frequently with their animals for pasture and for water. The region, and this is super interesting, this region is also the last area with trachoma in Uganda, and an area where the government of Uganda has faced significant challenges in reducing this disease. So findings over the last few years have shown that these groups have historically been missed during MDA. So this presentation is really looking at how we addressed this. So in order to address these issues of people having missed MDA, we knew we would need a multi-pronged approach to ensure health services are reaching populations in and around the Karamoja region. We knew we needed to understand many things, and some of those include who is being missed and why, how to increase the reach and demand among the pastoralists, how to reach migrant and mobile populations, and how to strengthen MDA to reach key populations. So implementing the Karamoja strategy, and I know some of you are familiar with this term, the Karamoja strategy. We use it a lot in Uganda with our work, and the government of Uganda has been paving the way for this strategy, as ACT East has been also. So we've been supporting the government to identify and design solutions to reach these key populations. Through a gender equity and social inclusion approach, we've used root cause analysis to better understand who is being missed and why. including the fear of side effects, absent men during MDA due to pastoralism and migratory labor, and among many other factors. The identified barriers to MDA uptake are being used to inform community mobilization messaging and MDA planning by government and Act East partners. And we are seeing really a good impact on coverage in these communities by using these approaches. We also have One Health. So this is, as we know, or as you may know, the pastoralist movement revolve around their cattle, and Karamoja being a very high, significant number of pastoralist communities and cattle. So engaging with the veterinary services and a broader One Health approach, the Karamoja region is critical if we want to reach the crowd leaders. So in recently, we have been having these conversations with the vets in the region. And what we understood from them is that if the cattle are happy, then also the people are happy. We even found that in sometimes they were, the people would take medicine if the cattle were also given a little something. So it's fascinating to see. They travel together. It's the crowd leaders and it's the cattle. And they prioritize their cattle and almost their own well-being and health over the cattle. So it's super interesting. It's dynamic that is very unique and one that is absolutely fascinating. I've gone off script here, but I'm going to go back to that. So using a more integrated One Health approach, we are seeing and hearing an increased demand for health services among these populations. All right, I have to talk faster. Cross-border, the location of Karamoja along the border and the movement of migrant and mobile populations is central to these efforts. We knew we needed to have strong coordination to ensure populations are reached, no matter where they reside. When the MDA is being implemented, and keeping in mind these communities, they're looking for water for the cattle, so they are constantly moving. Synchronizing the MDA with Kenya has taken a great amount of coordination and thinking beyond our standard MDA approach. The coordination is happening from the most local level and way up to the national trachoma level for MDAs. Micro-planning also underlies a lot of these approaches, and has been an important tool helping to determine timing, location, and modes of delivery for NTD services. All of these approaches are ways of reinforcing efforts to reach all the communities and making sure no one is left behind. All right, in conclusion, I hope you enjoyed the trip to Karamoja with me, but the story continues. This is not where it ends. This is just a snapshot, as you can imagine. This is a whole region with many dynamics. This is not business as usual either. We will continue to refine, innovate, and learn the best ways to reach the must-reach communities. As we say in Luganda, Mbwali Nyeo, and acknowledgements, just very quickly, I'd really like to thank the Ugandan government, the Ministry of Health, especially the Vector Control Division and the Department of Environment and Sanitation, Uganda, for their support. Thank you to the Kenya Ministry of Health as well for their collaboration. And we thank all of our Act East partners. Without you, we couldn't do this. So thank you so much. And that includes RTI, YHER, R4D, Save the Children, and all the other partners that are working in Karamoja. Thank you.
Good afternoon, everyone. My name is Molly Brady. I am the LF Technical Focal Point on ACT East at RTI International. My co-presenter today is Diana Stukel. She's the MEL Director at FHI 360 on ACT West. We're going to be talking a little bit today about some new and innovative data methods and analysis to advance NTD elimination. So as Sharon alluded to, in many of the national programs that we support, there's no easy MDA that's left, particularly for LF and trachoma. Many of the districts that are still doing MDA are caught in a cycle of failing surveys, not being able to lower disease prevalence enough. And because of the way that the MDA and the survey cycle works, national programs have to adapt quickly. There's usually not a lot of time for extra resources. So we're going to today talk about 2 activities that we've been doing within programmatic activities to gather more information about how we can respond to these areas with persistent and recrudescent disease. The first is what we've been calling never treated. It's looking at past MDA participation and including an indicator on that in pre-TAS and in coverage evaluation surveys. And the second, and Jeremiah alluded to this morning, is how we can adapt these coverage evaluation surveys to add questions of specific local importance. And just to note that in many of these approaches, we try to collect a variety of data at the same time so that we can look at demographics, infection status, treatment status, and see if there are associations between them. And just a final point that ACT West and ACT East have both worked with coalitions globally to try to help standardize these approaches so that data can be looked at across countries and lessons can be learned and shared. So one specific example of looking at the never treated data, and we worked with ICORDS to standardize protocols to collect this using the question that you can see on the left of the slide. On the right of the slide, you can see a graph that shows in a variety of ACT East countries the pre-TAS data that we found, with the purple triangle being kind of the mean of all the sites in the country, the percentage of never treated, and the circles being the high and the low. I think the key takeaway from this is that there's a wide variety of percentage of never treated, both among countries and even within a country. And so we've been able to use this data to kind of as a signal for areas of potential hotspots of ongoing transmission or needs for MDA improvement, but also to advocate with local stakeholders. So this is a specific example of some data from 33 sites in Nepal. The map on the left shows the prevalence that was gathered during pre-TAS, with the deeper the red color being a higher level of prevalence. And the map on the right shows the never treated prevalence, with green being less than 5%. And some of those red triangles that you see being over 40% of people noting that they had never been treated. And you can see that there's definitely some overlap. I think this data was important for 2 reasons. One, when municipality planning sessions were done, they were able to present this data to leaders who were kind of done with MDA. They were suffering from fatigue. They didn't really want to do it anymore. And when they saw, wait, in my area, 40% of people weren't treated, they kind of stepped up and renewed their commitment to strengthening the MDA. And the second was last week, WHO held a meeting in Nepal and India, a cross-border meeting, and they talked about some of these hotspot areas and the need to try to synchronize MDA there and to really concentrate in some of these pockets to make sure that MDA was well supervised and implemented on both sides of the border.
Okay. Thank you very much, Molly. So Molly talked about collecting never treated data in the context of a pre-TAS under the ACT East program. And I'm going to shift to talking about never treated in the context of a coverage evaluation survey in the context of ACT West. So ACT West piloted the never treated question in the last year in 6 countries and 7 coverage evaluation surveys. And that included Burkina Faso, Ghana, Guinea, Niger, Sierra Leone, and Togo. And what we really wanted to do was we want to know a little bit more about the characteristics of the never treated population so we could better focus there. So on this slide, I'm using Niger as an example for a couple of reasons. So Niger conducted a coverage evaluation survey in December of 2022 for trachoma. And not only did we pilot the never treated question in that coverage evaluation survey, but we did something quite separate to that. We also collected information on a double round of trachoma treatment because the districts that underwent this coverage survey were ones that had persistent trachoma, so they were hotspots. And so so I'm going to bifurcate the left side and the right side. The main aim of the double round treatment in areas of persistent trachoma is to get more medicine into the same people over 2 rounds. So we wanted to see through the coverage survey whether that was indeed the case. And if you look at the left-hand side, we asked whether people had been treated in both. So there were 2 rounds, one in March and one in November of 2022, that preceded the December coverage survey. So on the left-hand side, you can see that indeed 82% of those who were surveyed said, yes, we were treated in both rounds. So that's kind of what we wanted to see, as opposed to only some 8-9% that said, no, we were either treated in the March round or in the November round, but not both. Now shifting to the the right-hand side diagram, there we asked people about the never treated question. And what I mean by that is, were they ever treated over their lifetime of possible MDAs to which or for which they had access? And you can see that in the case of Niger, which is a little different from what Molly demonstrated in pre-TAS over different countries, that we had a fairly low proportion of people, 7%, that were never treated. You can shift it. Thanks. Okay, so we wanted to dig a little deeper for the never treated population, the right-hand side, in Niger. And so we're currently sort of dissecting all the data. We've collected data on education, profession, years lived in survey. I don't want to present that all here, but just to say, one of the things we looked at is age and sex to better understand the characteristics. So this is a depiction of just the never treated population and how they distribute across age and sex. So in the orange, you can see the never treated population, and in the green blue, you see treated at least once. So within, and we've got 5 age groups and then age and sex. So within each of the 5 age groups, you see there isn't a tremendously large variation between males and females in terms of being never treated, except maybe in the 25 to 34-year-old age group. But there is considerable variation across the age groups in terms of being never treated, and notably, though, that the 5 to 14-year group, the school-age children, have the lowest rate of never treatment.
As Diane just mentioned, one of the ways that we've adapted the CES is adding the never treated question to it. But we've also looked at different sampling methodologies of oversampling populations of concern, like the pastoralists, adding disease measures onto it, or as was talked about the importance of this morning, of adding some qualitative data collection on to better understand local challenges and identify community solutions. So one example that I wanted to talk about today was adding a specific question onto a CES in Haiti to try to figure out if MDA improvements worked. So we asked people who said that they were treated for the very first time in the MDA why they were treated. And as you can see, the majority said it was because a CDD convinced me. And a couple down more, you can see that people also said because there were crackers or food available. And this was great feedback to have for the national program, because these were 2 very specific improvements that had been made this year. So it was a good set of knowledge to see that those improvements were working and that they should be continued as we move forward.
Okay, thanks. So in the case of Act West, we adopted the coverage evaluation survey to include measures of the disease. So I'm going to highlight that with Togo's coverage evaluation survey that was conducted in support of the Schisto STH MDA last March. It was conducted in 13 USPs that were either hotspots or low performing in terms of coverage. Now, this coverage evaluation survey was really unique in that it took hematuria measurements on 1 school-age child per household at the same time as it collected the never treated information through the CAP questionnaire. And it's really the intersection of those 2 that we're interested in looking at, because the whole point of looking at never treated is it's thought that they may be a reservoir of infection. And the only way to know that is to look at their disease status. So you can see here what we've done is we've crossed the treatment status on the top row, never treated, treated at least once. With the column, their hematuria outcome, which is they're either positive or negative. So indeed, if you look at the far right-hand side, the statistical analysis shows that there's an odds ratio of 2.4. What does that mean? It means that you're 2.4 times more likely to be positive, hematuria positive versus negative, if you're never treated as opposed to treated just once. So that's quite significant. Okay, you can flip. Just have one more slide here. We also in Togo, interestingly, had GPS coordinates and were able to plot the location of the never treated kind of hubs to see if they were clustered in any kind of interesting way or significant way. So what we did was we constructed a village level indicator that looked at the percentage of households in the village that had at least one SAC with blood and urine positive and in the same household were never treated. And so you can see in the color coding, we did a range of percentages of such households that were either 0%, 1 to 5%, 5 to 10%. And so we also converted the household level GPS into a village level GPS. So the dots you see there actually represent villages. The first map on the left shows that there are two main clusterings in Togo where there seem to be villages with such attributes. And that's kind of indicated with the red dot and the pink dot clusterings. And we've blown up on the right-hand side so you can see better that there is actually a clustering of villages with these problems. So the question then would become, should Togo then put more emphasis on these two clusters of villages in future MDAs? And just one fast wrap-up slide. Sorry, I know I'm a little bit over. So in these two types of innovative data methods, it's clear that as programs near elimination, you can implement slight to moderate tweaks that are not terribly resource intensive to help tweaks to survey questions and methodologies that can really help you get at those last mile issues. And collecting and analyzing GPS coordinates are really critical to be able to visualize and place on a map where your problem areas are. And finally, standardization of questions and methodology is possible and highly encouraged and has clear benefits, as I think Molly and I have both demonstrated. So with that, I close and thank you.
Good afternoon, everyone. My name is Faraja Liamuya from NTD Control Program, Ministry of Health in Tanzania. Let me share with you our program experience on the involvement of the local communities to identify their own problems and create local solutions through microplanning so that we can increase the uptake of an intervention to increase the impact of our intervention that we are doing. Imagine what we can accomplish if the community owns the process. What the program is facing, despite several rounds of MDA, that takes up to more than 10 rounds in some of the districts. Yet, these districts are experiencing repeated disease-specific assessment failure. And where do we face this problem? This challenge we are facing, it's mostly attributed to the migration patterns of the fisheries in LF endemic areas and nomadic pastoralists in trachoma endemic areas. And this failure, the main reason is low MDA coverage at sub-district level. These groups of fisheries and nomadic pastoralists, they're very hard to reach, they're very hard to treat, and they have been consistently being missed during MDA, as we did not have plans that suits their lifestyle and culture to reach and treat them. WHO microplanning tool manual that was launched in March this year and they developed the training modules. Both were piloted here in Tanzania. The micro-planning manual, it uses the bottom-up approach to reach the target population. It focuses on the local approach in planning, implementation, and monitoring of MDA. In Tanzania, we did the micro-planning training at the national and implementation unit level. We prioritized areas with persistent low MDA coverage. Then we planned with the targeted communities, and also we engaged other sectors working with the same communities at the implementation level. During the micro-planning sessions, the communities were to choose the distribution channels, decide for the timing of MDA. They identified the resource needs for MDA, and also they planned for the monitoring. The community is the center of the process, so they lead that process of the planning. Also, we involved other sector like livestock, education sector, farming, fisheries. These people, they are working in the same communities. They have understanding and experience of their migration pattern and culture. So our programs can learn from them and adapt some of their strategies to reach these communities. Through microplanning, we have learned or we have been able to improve our MDA implementation, improved our community ownership and cross-sector engagement, improved the resource allocation, and this increased the visibility to do MDA in hard-to-reach areas. This improved MDA will accelerate elimination of these diseases in these hard areas that have remained. Now, in conclusion, microplanning manual developed by WHO is a useful tool to identify, analyzing, and solving challenges which were initially unidentified by the program. To implement it, it takes initial investment of the resources at the level of capacity building, and thereafter the primary healthcare workers in the community will continue to implement it. Tanzania NTD control program have used this manual, and it has helped us to improve our MDA. Now we know that better planning and more inclusive plans, they're very useful to ensure that we reach everyone in these communities. Lastly, the program would like to acknowledge the contribution from our partners and stakeholders in the process. Thank you very much for listening.
Bonjour à tous. Je suis Ndeye-Marie Bassabi-Aladji, la coordonnatrice du Bénin à NTD. Je vais vous présenter le parcours de la validation du trachome au Bénin en tant que problème de santé publique. En introduction, nous dirons que le Bénin
Just for introduction, we say that Benin is a country in West Africa, subdivided into 77 communes or districts. The trachome was announced in 2023 on the mapping that was done in Benin. 26 endemic
étaient éligibles au traitement de masse.
For MDA. All right, English channel. I think we're good to go. So with regard to the journey, just to explain the elimination dossier, we began drafting this dossier in 2020, and we made a first draft in 2021. We had a first session to adjust with regard to activities undertaken. In 2022, we had 3 sessions on this dossier in February, and in July with a committee of experts. This was unfortunately only implemented in 2022, and the last session was in September with the same committee, and then we transmitted the dossier to WHO in October 2022. In January 2023, we had WHO feedback. In February, we met again with the experts committee to act on to update with taking into account the WHO comments, and then we had the good news in March. The problem that we had in Benin is that the National Committee of Experts was established late and did not allow this committee to provide advice needed for the country. So this committee did not really play its role. And finally, to the evaluation of the dossier, it did not give the advice that was needed for the process. Now, which strategy did we use despite all that to realize the dossier? First, the program, we used the WHO directives, put a task force in place, and this task force was able to write this dossier. When the committee was established, when we gave them the dossier, they took the dossier and worked on it on behalf of the country, and then they were able to submit. We were able to submit it to WHO. The results that we obtained is that the dossier was validated by WHO, and we were able to work with the different partners in order to see what can be done in order to improve the implementation of the dossier. The committee of experts, unfortunately, was not able to advise and support the program. It was the partners of the program that really did the job. In terms of success, despite all that, the dossier was validated, and we had the celebration with all the partners of the government, and this was in June 2023. You can see on the picture the main partners from Ministry of Health, the site savers, and all of them supported us. We can say that Benin was able to validate the dossier thanks to the support from the partners. What we can recommend to other countries is that to put a committee of experts early enough before the implementation of activities, so that this committee can support all along the process. This was not able in our country because we had established the committee late. We worked with the other sectors so that, especially the wash sector, we should work with the water ministry and the communities and local leaders. Without them, you can't have a good dossier. In future, we're still looking for partners for the post-elimination activities, especially that, because when we finish eliminating the disease, there will be no more partners to help. So you in the room, we ask you to support Benin to continue with the activity. Elimination of the disease does not mean that this disease does not exist anymore. There are some residual cases. So we work with universities, training institutions, so that they introduce in their teaching curriculum, and that's what we've done for trachoma. Thank you. Merci beaucoup, docteur. Nous allons prendre des questions.
I want to see some hands. I want to see 2 hands. Okay, I have one hand there. Okay, we'll start with you. Teshome. Teshome, did you? Oh. Okay, I'm getting in trouble now. Was he so excellent? No comments, no observation. Okay, I see one hand. I can convince people. Okay, I have one hand on the right, two hands on the left. Okay, we can start. Please.
Hi, good afternoon. Thanks so much to all the speakers. One quick question on the never treated. I'm just wondering on this slide on trachoma, when we see the imbalance in that younger age group, I'm thinking maybe it's infants who wouldn't have been eligible, or syrup maybe is being viewed as different than tablets. And so maybe not specific to answer on the trachoma piece, but I'm wondering how is maybe qualitative research being integrated into that to really make that data come alive and understand in real time when the people are in front of us why they might not have been treated. And then a second piece, if we don't have time, it's okay, but back to Karamoja, I'm just wondering if you link up with Toposa on the South Sudan side. Thank you.
Please, yeah.
Thank you very much for that question. So if I'm to understand your question, it was about the 1 to 5 year age group, right? Where you saw an elevated proportion of never treated and why that might be. And you were positing on one hand, it could be because of ineligible. So trachoma is the one disease where all age groups are eligible, so we included them in. So we actually consulted with our trachoma expert whether that was the correct thing to do or whether we should have removed that. So that actually was a curiosity for us as well. Why in the SAC group we saw it diminished, and why in the 1 to 5 year age group we saw it elevated. And this is really hot off the press, so we really haven't had time to look into it, but it is precisely the question that we're trying to grapple with. And so stay tuned. I'm sorry, we just haven't really had a chance to dig in deeper and see why that discrepancy. But thanks for the question.
Thank you. And Sharon?
Can you repeat that, please? Yeah, so Karamoja, Turkana, and Toposa are on the South Sudan side. They're all kind of one people. And so I'm just wondering if there's any linkages on the South Sudan side, because there's a lot of movement across those 3 borders.
We haven't got that far yet, but we're getting there. And one thing that we have noticed, for example, is that when we did the cross-border collaboration with Kenya, is that we know that the Turkana, they want to be treated by Turkanas only, and the Karamojongs by the Karamojongs only, but we haven't got that far yet in terms of scope. But thank you for the question.
Thank you.
Thank you. I saw there were another hand. Okay, can you come and stand?
Hello, everyone. My name is Nori Johnny. My concern was for the last presenter. We have seen a lot of inputs the government have been doing just to combat this NTD, specifically on trachoma. I would like to know and understand about how youth initiatives are being supported and how the youth are being supported toward this end of trachoma in their country. I would like to know that. Thank you.
Merci. Par rapport à l'élimination du trachome au Bénin, le gouvernement a fait sa partition, mais aussi les partenaires. Donc, il y a eu un plan qui a été...
There was a plan that was put in place, and on that plan, partners saw what could be done. Partners saw what could be done. Government came and supported so that we implement the elimination. To the celebration, you saw contribution by government, same with partners. In the peripheral areas where the disease exists, the local elected people and other administrative leaders had supported the sensitization program. This made it possible for activities to be undertaken without a problem. And because it is a stigmatizing disease, people hide. But because it's the same people from the same community speaking to them, they came up, and the MTA went well, the operation went well. As you saw in the first slide, these are people who were operated and today can see clearly. We celebrated this on 13 July in Cotonou. The patients were very happy and appreciated the initiative, but the challenge now is the activities after elimination. Unfortunately, once we eliminate a disease, everybody goes away. So we would really like to have more support, because the government also said that you said you have already eliminated. What else do you want? But actually, it's now that we have more to do. Thank you. Thank you, Dr. Marie. Je vous remercie.
They deserve a round of applause.
Thank you.
So I'm going to hand over to Geshi.
Thank you very much to the panelists and to our moderator. Mao, as you said, it's that time in the afternoon when energy is a little low. So I have one task, and that is to get everybody's energy from 20 to 100. And we're going to do that with a trivia. There are two things that you need to do. I know you usually don't get instructions like this. Usually we say, put your phones away. But for this instance, take your phones out. Take your phones out or take your laptop out. Next, I want you to go to menti.com. I think our tech team is about to show this on the screen in a minute. Take my pretty face off the screen. There we go. Good. So please scan this QR code. If you don't have a scanner, please go to menti.com. You need to enter a code, and the code is at the top of the screen, 35 12 55 9. Now, while you're doing that, I want to tell you a couple of things. I know you're all used to everybody's a winner, nobody's a loser. This is not the case today. There will be a clear winner. We have a gift. No money was spared. We went and got the best coffee and the best tea that Tanzania has to offer. So that's what's on the table for the top two individuals. Now, this game is about speed and smarts. Yes, I said it, speed and smarts. If you're smart, you will be finding yourself going home with one of the coffee or the tea. All right, are we ready? Tech team, are we ready? All right, to the first question. Yes, yes, yes. Everybody's ready. We have 83 players, 85 players ready to play. And I want to go to the first question. How many countries globally have eliminated at least one neglected tropical disease? There are your options on the scale: 22, 35, 50, 56. And counting down, it's about speed, guys. It's about speed. All right, looking good. We have some listeners in the room. The correct answer is 50. Well, we have 14 listeners in the room. All right, let's give this another shot. Next question, please. Oh, all right. Well done, Lisa. All right, question 2. Let me give it a second. Approximately how many people are affected or live at risk of NTDs today? 150 million, 750, 2 billion, 1.7 billion. Time is ticking. And we come to a close. Well done, 44 listeners. 1.7 billion living at risk of NTDs. It looks like these were too easy. So let's get into some harder questions. We still have Lisa on the leaderboard. Let's see if anybody would knock her off. And we're going to the tougher questions now. So please pay attention. NTDs are not only making incredible public health impact, they are also award-winning. Which of these awards have been won for connection to NTDs? Nobel, Guinness, Albert Einstein, both A and B. And excellent. Yes, both A and B, Nobel and Guinness World Record. A whopping 200 million doses delivered in just 24 hours to 6 countries. That's what's got us onto the board. All right, well done, Shami, kicking Lisa off. And we keep going to question 4. To date, how many countries have or are developing NTD sustainability plans? 3, 8, 12, 16. And that's right. USAID has supported 12 countries to develop sustainability plans, and there's still more to do, which is probably why our next panel is going to talk about that. But stick with me, a few more questions so that we get a clear winner for this trivia. I missed that, but in question 5, during the film Godfather 2, Vito Corleone is checked for which NTD when entering the US? Yours, trachoma, leprosy, snake bite. This is a good one, right? Yeah. And 30 people know that it is trachoma in Ellis Island in New York Harbor, the busiest immigration inspection station. Well done to everybody who on the board. I see that Lisa is no longer featuring. Well done, Joe. Welcome to the top, Joe. Next question. And the question is, NTDs have been referenced in which of these historical texts? Bible, Talmud, Ebers Papyrus, all the above. And the answer is all the above. That's right. NTDs have been wreaking havoc for centuries, guys. Leprosy, schistosomiasis, guinea worm, trachoma are referenced in all these texts. And we still have on the leadership road, it looks like Joe is going to distinguish himself from all of you all. So moving on to question 7. How many NTD treatments have governments delivered to populations at risk with support from USAID? 450, 985, 1.5 billion, 3 billion. If you are listening to Darren's presentation, this would be an easy one. And it looks like it is kind of an easy one. The answer is 3 billion. That's right. Since 2006, USAID has delivered more than 3 billion treatments. How are we looking here? That's right. Kyle, welcome to the top of the board. Okay. We're almost at the end. Question 8. How many continents are affected by NTDs? 2, 3, 6, all 7. And the answers are in. It is C, 6. Only Antarctica does not have NTDs. If you're willing to move there, Africa remains the most affected with the highest number of individuals with NTDs. We still have Kyle at the top and Barefoot Contessa. Welcome to the top. All right, everybody. Now here's where we distinguish who walks away with this tea and coffee. Question 9. Soil transmitted helminth eggs can remain in the soil for how many years? 1, 5, 11, 18. All right. And the answer is 5, everybody. They can stay in the ground for at least 5 years, sometimes even longer. And with that, tech team, let's see who is going to be walking away with these prizes. It's going to take a second here. And the final answer is in. Barefoot Contessa, well done with 63.91 points. Whoever you are, find me. You'll be going home with one of our lovely gifts. And ET is second on the board. Find me as well for your gift. Well done, everybody. I hope that energized you a little bit. I'm going to stay on stage with you, and I'm going to ask our panelists to join me on the podium here, please. All the panelists, please make your way. While they're snaking their way here, I think you can see on your agenda, we are now going to talk about government leadership initiatives for NTD service sustainability. And what we've asked our panelists to do is to focus on the nexus of NTDs and health system strengthening. We have 4 ministries who've made their way to the top of the podium, representatives from Tanzania, Ghana, Togo, and Ethiopia. But first, we're going to set the stage. And I'm really excited to invite Emily Wainwright, USAID's Senior NTD Advisor, to kick us off. Welcome. For your information, some of our speakers will be speaking in French, so have your handsets ready.
Right. Thank you, Getchi. I got to pull out my readers now. Since we're talking about a lot about trachoma and eye care, I had cataract surgery earlier this year, and I'm still trying to figure out what my new vision strategy is. So trying to figure it all out. So just want to say good afternoon. And now I think we want to take a little time and shift away from the morning conversation. As someone who joined the USAID NTD team 12 years ago, I think this morning was a real kind of immersion into some very technical issues that need to be addressed to get us to achieving elimination. And when you think about the WHO Road Map and the new one and the 3 pillars, I think this morning was very much about pillar number 1. And so I think it's exciting, but now we're going to start looking at the other 2 pillars. And pillar number 2 is a conversation about mainstreaming NTDs into national systems. And pillar number 3 is also what I call, I think, a particularly interesting challenge to look at. How are we supporting and working with governments to help them achieve their priorities, and particularly really support country leadership? So we'll pivot into this view for the afternoon. As you all know, WHO has created the Sustainability Framework for Action against NTDs. And this was really an attempt to move us beyond just looking at disease-specific programming and say, how can national systems and national services best support and advance the control and elimination of NTDs. For USAID as a development agency, we took this challenge quite seriously and have started working with a series of countries to look at how do you operationalize that sustainability framework in their country-specific context. And we have spent the last couple years working with about 12, and now it's 14. They're bringing in 2 more, even though Getchi had it in the test, to work with countries to say, if you're developing a sustainability plan, looking at a multi-sector approach where they are defining what they say is their definition of a sustainable NTD program in their country context. Who are the stakeholders in country that they want to be working with? And 3, how do they leverage national systems for NTD services? And as these countries have gone through that process and really started to define their vision of sustainability, when they're done, we actually are using that as an opportunity to start a conversation with them about, like, how can we support parts of that sustainability process? One of the things we're finding particularly interesting in moving forward in that and taking a look at the pillar 3 is, how do we work with governments differently to get to sustainability? And as we've been struggling through this process with them, we are starting to look at a set of principles that are guiding the way that we operate and engage with governments that I'd like to share with you today. And so the core principles that are emerging in that is, 1, supporting one government-led sustainability plan. Many governments are developing their sustainability plan. How can we support that vision and invest in it and not be at conflict with that process? 2 is using national systems to get the job done. There's a lot of things that are happening in countries. There's parts of government that actually provide services, have systems in place. How do we use those instead of necessarily parachuting in someone to get the job done, but really looking at how governments can do this? The 3rd is really reinforcing government leadership and their ability to leverage national systems. I think we worry about providing technical assistance or program support that undermines national NTD program managers as they are working with their systems to figure out how to create sustainable programming. So it could be a great opportunity that they are negotiating with some part of government. We want to make sure that the technical assistance that we're providing doesn't undermine that opportunity. And also looking at, how do we monitor progress? Governments with sustainability plans have beautiful benchmarks and timelines in them, and really work with them to say what's their definition of success, and using that as our benchmark. And then the last part that I think is something we really need to think about, we've been very impatient. We like MDA to happen fast. If we really want to have sustainable change in national systems to support NTD programs, we need to be willing to be patient and time and be willing to live with taking the time to make sure that those systems embrace NTD services and make them available. And that probably won't happen overnight, which kind of flies in the face of I would say, the urgency and the persistence that we see in a lot of the MDA challenges that were discussed this morning. I would say, even though governments are working on developing sustainability plans, a lot of work's already going on. So I would never want anyone to think governments haven't been working on this. They're definitely working on this. But I think what we've really found quite exciting is there is a lot of work being done. And I just kind of wanted to give a snapshot of what we're seeing. And I want to be clear, this is not everything. This is to give more of a flavor of what we're seeing with governments that we're having the privilege of working through. So there's a lot of work going on with governance. We see governments are developing sustainability plans. They're getting politically validated. You can find them on their national websites. And they're looking at what's the accountability structure to measure project progress. Coordination has been a huge issue. I think earlier today we heard a lot about cross-sector collaboration and coordination, and that's using NTD platforms, and it's also using other platforms in country to really look at how to best coordinate across sectors. And then a lot of discussion about domestic resource mobilization. Some are looking at how are you engaged in the national budgeting process. Some are looking at health insurance reform. Some are looking revision of essential packages services. These are all a lot of stuff going on. And once again, not all inclusive. This is just kind of a snapshot of what we're seeing. And then the other part that I think is really exciting is looking at some of these cross sectors, if you want to say, some people talk about building blocks, but we're of health, but we look at health information systems, supply chain, you can be looking at the workforce and service delivery platforms, and looking at how those systems that exist in country can better engage, support, and advance NTD services. So there's a lot of that work going on out there in various stages, which I think is really exciting. I gave a version of this presentation in June at the partners meeting. And one of the questions I heard on the break was, well, we see that, but what does that mean? What does that really look like? And so I think the exciting part is I get to show this, but now they get to tell you what it actually looks like. So this is, we get to turn over to the real stars of the show who are getting the work done.
I'll go ahead and introduce our next speaker, Douglas Ndeki, Health Secretary, Quimba, DC, President's Office of Regional Administration and Local Government. Welcome, Douglas.
Hello, everyone. As I've been introduced, my name is Douglas Ndeki. I work with the President Office, Regional Administration and Local Government Authority. I want to take you through Tanzania success and challenges in financing of NTDs. Tanzania launched its first ever sustainability plan in early 2022. The sustainability plan we established has, among other objectives, an objective to increase domestic financing up to 60% by 2026. We identified strengthening council planning and budgeting as our key entry point. And this was supposed to be done through capacity building of key council planners, integrating NTD in Plan Rep and DHS2 system. As we know, Tanzania, we have the specific system for planning, we call it Plan Rep, and to improve NTD budget tracking. So before I take you through what exactly we did, let me share with you some key NTD financing challenges in Tanzania. NTD financing in Tanzania is challenged by, firstly, competition of resources because of its position in the CCHP guideline. NTD are placed at priority area number 3, alongside other diseases such as malaria, HIV, and since NTD have low prevalence, being at elimination stage, they get little resources because planning in Tanzania is data-driven. Again, there was a inadequate knowledge and use of planning and budgeting system specific to NTD coordinators and other planners at the council level. As we said, as we have been saying, it is very important to look the aspect at the primary health care at the district level. If we can improve there, we can gain sustainability and sustain our gain. So our planners at the council level had inadequate knowledge of using planning tools and planning, of course. There was also inadequate data availability in DHIS2, and this is the main tool that is used during planning of the CCHP. So absence of NTD data in the DHIS2 somehow hindered the quality of plans we are preparing at the council level. So what we did, we started by stakeholders mapping. We just wanted to know who are our stakeholders, what do they do? After that, we conducted financial analysis. The financial analysis we conducted came with the finding that 49% of the council did not plan at all for NTD interventions. Again, we noted that NTD intervention in Tanzania are heavily donor dependent, and the donor funding was also decreasing. So we had to do something. Where did we start? We started by sampling 15 councils. We capacitated them on planning and budgeting, use of epidemiological data to inform their plans, as well as use of these tools, PlanRep and DHIS tool, in order to help their planning. After that, we allow them they went for planning and we assessed their plans. After the assessment, we noted significant changes. The first changes I like to note was expansion of costing centers for NTD budget. Previously, NTD were only budgeted at the management cost center in the district level, the council health management team. But after this capacity building, they are also allocated at the facility level, the hospital, health center, and dispensary, and which increased the funding. Again, we noted that there was increasing of funding sources at the council level, because planning at the only cost is at CHMT cost center management, we lacked an opportunity to utilize facility collection, such as insurance, OPP, etc. Eventually, we increased the domestic budget in 2021 and 2022 by 12%. Process, we learned that engaging key council planners, specific district health secretaries, planning officers, NTD coordinators is key in increasing domestic financing. Again, we noted that effective NTD planning and budgeting is enhanced by NTD data in DHIS2. We noted another opportunity, a very good opportunity. There was an opportunity to use council-owned sources to finance NTD interventions. However, in order to utilize this opportunity, there is a need of doing targeted advocacy to district executive directors who are accounting officers of these important institutions. So after learning this, what have we done? We have successfully incorporated the situation analysis tables and assessment criteria in the PlanRep to aid us on the other end, assessing the quality of plans, and on the other end, to have specific NTD data to aid us in situation analysis. And currently, we are developing NTD-specific service output codes. These are very important as they will help us to track specific NTD expenditure at the council level. And we have developed and incorporated DHIS2 specific indicators in the NTD specific indicators in the DHIS2. And currently we are working on interoperability between, thank you, between expenditure system at the council level and the facility level. At the council level, we use what we call mfumo wa malipo serikalini, MUSE. And the facility level, we use what we call facility financial and reporting system FAS. So we are working on interoperability of this in order to help us with tracking of expenditures and budgeting implementation. As I noted it earlier, it is very important to have capacity building for key planners, and we are targeting NTD coordinators. By that, we have developed the operational manuals to help them, to guide them in planning. We are also developing NTD planning and budgeting training models for NTD coordinators. As I noted earlier on, also the need of advocacy, we have developed a policy brief in collaboration with PORAG and Ministry of Health. This will help us in advocacy, and it will help us to address the key challenges for sustainability of NTD interventions in Tanzania. And this will also be used to sustain gains at the cross-cutting ministries and the department is related to NTD, because it's a policy brief that at a national level. We are also working on building evidence for NTD domestic financing using a council level financial strategy. And that is underway. It haven't been completed, but we are developing this strategy, which will give us evidence on finances. Allow me to finish by thanking the President's Office, Regional Authority, and local government, specifically Dr. Paul Chaote for his technical guidance and leadership. I would also like to acknowledge the Ministry of Health, Dr. George Kabona, and his team for his technical leadership. Thank you very much.
Thank you. Thank you, Douglas. I want to introduce the next speaker, Dr. Kwao from the Ghana Ministry of Health. Welcome.
Good afternoon. Today, I'll be talking on government leadership initiatives for sustainability, focusing on integration of NTDs with primary healthcare in Ghana. I'm normally the National Leprosy Control Manager, and I'm speaking on behalf of the Director of Public Health, who has to be at the UN General Assembly. Okay, I'll start by talking about some of our successes as a country, focus on the health system pillars and some innovations, opportunities for NTD sustainability, talk about some of the strategies we are implementing as well. Now, Ghana has a strong health system which has been able to deliver on various public health NTD targets, and is testament of our strong leadership and commitment at all levels. We have achieved various public health targets with respect to guinea worm, with respect to human African trypanosomiasis, and trachoma. Dr. Parry talked a lot about that earlier in the morning. We have also reduced the prevalence of a good number of our NTDs, including interrupting transmission of LF in 108 out of 114 endemic districts. Now, this is our president receiving an award, a major achievement award for Ghana eliminating 3 NTDs during the recent head of states meeting, the ECOWAS bloc. Points to the good work that is already happening in Ghana as well. Now, what are the health system pillars and that offer opportunities for NTDs? We know that since 2003, we have had a national health insurance scheme which aims to take away the financial barrier to care, covering about 95% of conditions at the primary healthcare level. And over the last few years, the ICC has worked to make sure that we are moving towards expanding the coverage of NHIs for NTD activities. Then the government is going ahead to implement what we call the networks of practice, aiming at strengthening the public health system. I'll talk about that later. Then there is taking advantage of our experience during COVID-19 to expand e-learning opportunities and start what we call the GHS Learning Institute. We have an efficient logistic management system, which has been further enhanced by a digital solution to ensure that we can reach the last mile, and piggybacking this with NTDs ensures that we can have an eye on consumption and minimize losses. Then, of course, we have the nationwide DIMS2, which has been in place since 2012. And allows generation of near real-time data from the implementation level. And data is available at all levels of the health system for decision-making. We also have an inbuilt performance management system at all levels, which allows us to use the health system to work for us. Once you're assessing health managers based on NTD indicators, they would ensure that it will ensure ownership and make sure they work for us. I already mentioned this in the earlier slide. we are taking advantage of ICT to expand learning opportunities for our staff without disrupting care delivery. We have the policy in place, we have the strategic plan in place, we are going on to resource regional centers for e-learning, and we plan to operationalize the GHS Learning Institute. That will provide us a platform to build and maintain HR capacity for NTD, and we are looking at developing facilitated e-models for NTD, and then going on to promote the use by the relevant cadre within our health system. This is a new concept, the networks of practice, and the idea behind this is to strengthen the weak link in our primary healthcare system, which is the sub-district level. So we organize all our health assets around what we call model health centers. And these are considered together, they are credentialed by the NHIs. By putting NTDs into this mix, what we are doing is improving access to services, because that's the routine health services being provided at that level. And within the system, the key roles are played by community health officers, community health nurses, and volunteers. Now, every system needs to manage performance, and we have an established system using many tools, including a holistic assessment. We have the peer review process where districts, hospitals review each other yearly. And then we have an integrated supportive supervision. And since 2021, we have developed a digital app that has enhanced that process. Now, if we can, and we have included some already, NTD specific indicators into these tools, it ensures that at every level, there's ownership. There's increased attention for NTD interventions, and that drives the mainstreaming of NTDs. What other things are we doing? We spoke about the community health officers earlier this morning. Dr. Barry mentioned we have adapted the home visit register so that when the healthcare worker goes to the home, they are also assessing NTD elements. We've gone ahead to revise the standard treatment guidelines to include all NTDs. This has a bearing on the essential medical medicines list and then the benefits package for NHIs. Dr. Perry mentioned in the morning that we've done curriculum revision and it included LF. We're going ahead to look at opportunities for other NTDs as well. We're not stopping there. Okay, we're not stopping there. We're going on to develop manuals and then to train the tutors that will train the healthcare workers at the basic level. We have the research division that oversees all research activities in the health system. Every level is supposed to carry out at least one research every year. So by integrating our work into the RDD's work, we will have the health system answering the questions we need to be answered. And of course, the NTD programs, we have separate NTD programs structurally, but we are meeting together more, planning together more, and working together more. Now, I am concluded. We have made a lot of progress, you know, and you have seen. It hasn't taken our effort alone. It's a collective effort by the Ministry of Health, Ghana Health Service, and our partners and our hardworking staff. And we recognize the commitment government continues to make, covering most of the costs related to infrastructure, human resource, equipment provision. We, however, recognize that mainstreaming NTDs into PHC is the way to go, taking advantage of the existing health system structures, and then fostering integration across disease programs, across other sectors as well. Now, if we are to support MOHGHS to strengthen these pillars for NTD services, we'll be going a long way to build sustainability into whatever we are doing. Thank you very much. Integration, mainstreaming is really about making sure that we leave no one behind. Thank you very much.
Thank you. Thank you very much, Benedict. Thank you. I want to welcome our next speaker, Dr. Nosike, NTD Program Coordinator, Togo Ministry of Health. Those of you who do not speak French will need your headset.
Je vous remercie. Je sais que nous sommes un peu fatigués, mais Saira.
Let's proceed. My name is Dr. Inosubiki. I presented myself. Today I'm going to share with you an initiative from Togo on the ownership. Two ministries, Ministry of Health and Ministry of Education, that have established a partnership in order to develop something. You already understand the context. I'm not going to dwell on that too long. We are at the moment moving towards the elimination of ONCO, SCH, STH, and today we have prevalence that are quite low, be it at the level of STISHO or OV. Concerning the ONCO, we also are aware that we've stopped the treatment in one of the region out of 5. But in front of this success, we have a challenge in Togo. The MDA is incorporated, integrated to provide treatment against ONCO, but also treatment against schisto. So it is the onchocercosis platform that is used to do the testing of children. Now that we are moving towards the elimination of ONCO, it's important before that we reflect on what we are going to do next, when we will no longer have ONCO, because schisto, especially, we understand that the elimination is a bit difficult. So it is in this context that the new platform needed to be tested. And the new platform that was presented to us is the school level, which is basically the work of my presentation today, because in the framework of the NTD 2030 vision, Togo has also developed its master plan and its sustainability plan. One of the recommendations of priority was exactly this, to find a platform that will be able to take the place of the ONCO platform once we had eliminated ONCO. So we found this platform in which we've undertaken activities. Now, these activities started since 2021, 2022, with discussions and consultations between the two ministries, Ministry of Health and Ministry of Education, in order to move towards the formalization of this partnership. We already had started to work together, but we needed to formalize this partnership. That is why, thanks to the leadership of the two ministries, the two permanent secretaries, we were able to have a bilateral agreement, as you can see on the PowerPoint, that was jointly signed by the Ministry of Education and the Ministry of Health. And what is contained in this convention or agreement, not only does it talk about the treatment of children in schools, as I said, but also goes further. In this protocol, it also talks about required tools in order to talk about NTDs to children in schools, because we understand that it's from the school age that we need to sensitize on the good habits. What are the tools to develop and to put in place so that in schools, children are able to hear about NTDs, since 90% of children in Togo goes to school. And each ministry had a task to do. On Ministry of Health was supposed to support the Ministry of Education. But the Ministry of Education also was supposed to provide free treatment to children. So here, I do not want to go into details. This convention concerns all the levels within the two ministries, be it at the central level or the decentralized level. So thanks to this agreement, together, we were able to put in place this pilot project that was established for the first time in the region, that was able to put an end to the treatment. And we had selected 2 districts in this region. And this pilot project had involved over 674 schools, 4,850 teachers and directors, and was able to mobilize over 112,000 children. That took place in the schools, but also within the community for children that were not going to school, but also for adults when we needed to provide a treatment for adults. In conclusion, Togo has moved forward. We are very soon going to eliminate onchocerciasis, but the platform that is used for the onco and for screening of children, it is true, this might appear to be going on the opposite direction. We understand that in 2022, WHO had published recommendations and rather encourages country to move towards a community treatment. And we are moving away from community treatment to move towards the treatment at schools. This project that we've already undertaken, we have already obtained some results, and this is really encourages us. And we believe that if it succeeds, it will be the ownership of this program, because if teachers are able to convince to have the treatment freely, it will reduce the costs and will allow Togo to continue even when we will no longer have this platform. And I thank you.
Thank you. Good afternoon and hello again. So I will take you through a brief presentation on mainstreaming of NTDs into the national healthcare financing strategy in Ethiopia. Sorry. As we can see, the country is one of the high burden country for NTDs. We have about 13 administrative regions. Each of the regions are endemic at least 4 to 10 entities. And currently, with the current strategic NTD national strategic plan, 12 entities are prioritized for intervention. And this is the government of Ethiopia who is responsible for the overall coordination of the NTD program, as I said during my previous presentation. So as a background, the Minister of Health has launched the healthcare finance strategy in 1998. And the NTD Sustainability Action Plan, as well as the NTD Strategic Plan, was launched in 2020. The NTD Sustainability Action Plan has identified domestic resource mobilization as one of the pillars of the health system building blocks, or the NTD Sustainability Action Plan. And the ministry was also endorsed the essential health service packages, which include more than 1,000 health service packages. Of these, 570 were exempted service, and about 387 were under the health insurance benefit packages. After the 3 years implementation of that strategy, the government has realized that there should be a revision on that strategy due to certain challenges and reasons. So to see some of the rationales why the government wants to revise its healthcare finance strategy. The first one is there has been variation in guidance and implementation of exempt health services across different programs and across different regions. And health facilities were not able to reimburse the cost that was used for different health services, including direct procurement, medical supplies, and so on. And there was no clear and defined set of service lists under the essential health service packages. And as an objective, we would like, the ministry would like revise the essential health service package, considering the ongoing government, new ongoing government initiatives, as well as the country physical space, and having a positive listing of health insurance benefit packages. So as a solution in 2023, the ministry has established technical working committee who will work on the revision of the strategy. So NTD is represented by 2 technical experts who will work with overall technical committee during the development of the revision of the new strategy. And currently, the technical committee identified about 106 high priority interventions for the revised exempted health services. And of these, some of the NTD service packages are identified as or included in the essential health service packages, as well as there is some of the morbidity management related services are included or prioritized as part of the essential, the health insurance benefit packages. And the Minister of Health is working on a resilient and equitable health fund, which is inclusive of NTD program. So those are the tips that established working committee came across during the revision process. The first one was list revision and harmonization and costing and prioritization of program, health services in from all the health programs, including NTD. They used a certain criteria for prioritization and alignment with the health insurance benefit packages, and financial space and financing options were also identified. And currently we are drafting legal framework and it's under development. And the next step will be approval from the Minister of Health as well as the Minister of Finance. So those are the work in progress. First one is, as I had said, approval from both ministries, and there will be legal issue framework development, resource mobilization, advocacy with Minister of Finance, regional finance bureaus, and the regional government in general, and so on. And the last step will be approval and implementation. So what are the lessons that we learned during this whole process? The first one is capturing policy, all available policy windows, and identifying appropriate entry points is very critical to ministering the NTD program into the general health system. And the second one is ministering NTD into domestic resource mobilization will support progress and toward having a sustainable financing for the program, as well as for having equitable and universal health coverage. A collaboration with technical working committee will create trust, acceptance, efficiency, and long-term solution for the program. And political commitment and leadership is very critical by far for any significant policy and strategic change. In closing, so we are very much committed to strengthen the health system and the NTD sustainability based on the 6 health system building blocks. And I would like to acknowledge all partners who have been with us, especially the activist USAID support, because unless and otherwise, we are, we build a resilient and sustainable NTD programming. The impact that we got may not be a long lasting. So we have to have a mechanism to sustain the program. And it's very important to have continued strategic investment and technical assistance that contributes to a long-lasting solution for NTD. Thank you.
Thank you very much, Fikre, and thank you to all our panelists. Ladies and gentlemen, the Q&A is open now. I welcome you to raise your hand, come up to the microphone, and please do direct your question to a panelist or to anybody. Welcome, Lindsay.
Thank you, Getchi, and thank you to the panelists for such a stimulating session. I felt really uplifted by these presentations and some earlier this week showing real demonstrative change and in growth and national investment in NTDs and in some cases in UHC in general. My question is, could each panelist state which specific one thing you think has been most influential to progress you've seen in your country's ownership of NTD programs?
Thank you, Lindsay. Panelists, please feel free to grab the mic closest to you. I believe the question is for each of you. Happy to start right there with you, Dr. Kwao. No luck. All right. Thank you.
So thank you for your question. I think on the slide where I spoke about the successes in Ghana, right at the bottom was where we had mentioned the revamped NTD Intra-Country Coordinating Committee. Hitherto, we had one that was not very functional, but now has been reorganized, revamped, placed right under the office of the Minister of Health. We have a very committed chair within the minister's structure, and that organ has championed many of the efforts at integration, engaging other departments to ensure that NTDs can be included in what they are doing. You know, engaging PPME, which controls the DIMS, engaging ICD, looking at the home visit register, engaging the leadership of the NHIS. You need that form of high-ranking coordination organ to really drive change. And it's not just within the health system alone, with other ministries as well, talking about WASH, talking about education as well. So that really for me has been the game changer, and all of us have been carried along, and we are working hard to make sure that NTDs are well integrated into all that's going on in the country. Thank you.
So in terms of sustainability, as I said, healthcare financing is only a single entity for the program to be sustainable. So we have, of course, we have a number of best experiences for the, to make sure the program is well mainstreamed into the health system. So we can see in terms of the supply chain management, it is very well integrated with general health system supply chain management and the workforce. So we have NTD program structure at all levels of the government, and we have a multi-sectoral coordination platform, which is a One Health, and so on. And some of the NTD packages are already included into the curriculum. I can mention the trachoma elimination program. So it is already included in the early primary school and so on. And we can also speak on the data management, which is very important for the program sustainability. So the national health, reporting mechanism is inclusive of NTD. So we have about 10 high-level indicators included into the DSISO and so on. We have a number of experiences, and above all, NTD is already included into the General Health Sector Transformation Plan, which is the high-level document. And yes, some of the indicators are being monitored by the Parliament even. So I am supposed to report for the Parliament. That's an excellent move forward. Thank you.
In our case, for me, I would say it has been collaboration between ministries, partners, and partners. For instance, integration of NTD indicators and DHIS2 or PANREP require approval from, say it, Ministry of Health, and the implementation is done by the PRAG. So it has been collaboration between partners at the national level. When things are discussed, we see if we need that, and after noting that we need this changing, they are shaped at all level, and then we get approved very easy because of that. Again, I should note the leadership from ministries, specifically at Ministry of Health and PRAG. Dr. Chaute has been very much flexible in shaping the outlook of NTD in the PlanRep. Even after planning session, he would ask, what can we do to improve this? How can we help in tracking? And we have been doing a lot of improvement to shape outlook of our plans. So for us, it's collaboration and leadership.
Quand on parle en dernier, on a peur de ne rien à dire. Ce que je
say what I think I can add here is the support. That is a long time partners and government have been working together. The partners gave up 90% and sometimes even 100%. Got to finance and technical support for a work in a country. Today, when the partners will leave and they will have to hand over to the ministries, I think the main issue here is the support. We have to support the ministers and ensure that the program is at the center of all decisions, so that when partners are no longer there, ministries should be able to lead the way themselves.
Emily, anything to add? Thank you. Welcome to the microphone.
Hello. All right. Thank you very much. And I congratulate all the presenters for the great presentations they made. My question goes to Dr. Douglas Ndeki. You know, for domestic resource mobilization or integrating NTDs into health system structures, oftentimes program managers lead this, and they are not often natural at it. The program managers, most of them are epidemiologists. Most of them have done district health management and all of that. They are not quite natural at it. But the first point is that for you sit from the president office. I think that is a plus for Tanzania. But for most countries, they are having a difficulty even having somebody at the ministry level advocating for them. And then also having the necessary skills within the NTD program or even in the health service to lead this work. I think from your presentation, I think you are leading that quite well. What have you found to be let's say, the capacities that NTD programs will need to be able to do some of the things that you are leading to help the Tanzania make sure that they utilize local resources to leverage the integration and then also push NTD forward. Thank you.
As you noted, of course, the program managers are health system managers or health services managers, but our system in Tanzania are coordinating in such a way that at a ministry level, the program manager have an administrator who work as a health system strengthening coordinator. And we at the president office, what we do is just implementing what ministries think. It's a two-way traffic. The Ministry of Health System Strengthening Department, what they do, they think, they strategize, and for us, we are weighing how can we adapt and implement such changes that were brought from the Ministry of Health. For Tanzania, we have that advantage. So back to your question, what capacity are needed? I'll think we need some financial analysis skills at the program management level. We need monitoring and evaluation skills. And we need some economical thinking of health intervention at the program level.
Thank you very much. We have one more question here. Justin, please.
Thank you, Wangashi, and thanks to all panelists. This is really a very important momentum. I have a question. Mine is for Emily. Same question Ernest asked it to government officials, but this is for donors to have some perspective. But let me just highlight one point. Probably is some of the complexity we don't see in this room when it comes to presentation. I had a chance to travel to Togo once, and I saw in the office of the NTD program manager the notes the minister sent before adopting the sustainability plan. And it was with handwriting, change this, explain me this with a red pen. So when I asked the question, how you perceive this, you say, oh, l'autorité met beaucoup de pression sur nous. The authority, the minister is putting pressure on us because he's showing us that I'm following what you are doing. I'm sure that on all this story, there are situations like this when you engage with high-level officials in the process of sustainability planning. So my question for Emily is, this is a long journey. It's sometimes complex. Countries are engaging. If you look forward and look into the future, what you consider as one of two things really donors, partners should emphasize beyond the principle, but what really should be emphasized, cannot be left aside to help these countries to continue in this journey.
So, okay. So I'm not exactly sure what you were getting at, Justin. I think I think the panel here gave examples of the complexity of the issue that's being addressed. And I think if we're really looking at sustainable NTD services, and that's the higher level target for the 2030 roadmap. Like, how do we get there? And we're not just talking about PC diseases. There's a lot of great work here going on with eliminating the PC diseases, but I think it was very clear that just because you've eliminated something according to WHO criteria, there's still a lot of work to be done, right? That's just, I mean, still with regard to the disease that's quote unquote eliminated. And I really appreciated the conversation earlier in the day about the disadvantage the word elimination can create for what you're trying to deal with, especially at a time when you say, okay, I'm eliminating a disease, but now I want to figure out what to do with the other 7 or 10 NTDs that exist in country. And so I think as a donor, and in our community, as we look at how do we support countries, I mean, it's really a time when we need to take a step back and say, you know, how do we support your vision? How do we find the time and the patience? I'm not sure it's for everyone. I think, you know, not everybody is comfortable with this space and health system strengthening and how do we move forward. And so to just say as a donor, you know, I think we just kind of need to reevaluate what are we comfortable with? How can we best support you in the vision that you're creating for your countries, and that we really need to have the patience to work with you. We're not going to get, it's not fast. If we want the change you're all talking about, you're working on it right now, right? You don't, it's not done yet. And so we need to actually stay with you and be willing to work through that. And I also think we need to support you differently than the way we have over the last 17 years. MDA is really important. We're all very invested in that, but I think we need to have a different vision about how we work with you and support you to deal with some of these systems issues. So I think it's a real challenge. It's a challenge for us to figure out how do we engage with you differently while you're putting these new challenges and I think opportunities on the table. And so I think it's, you know, it's a real time for us to think about how do we do business differently. I agree with Lindsay's comment that the stuff that you were talking about today, very inspiring, hard work, but really, really, this is why I get up in the morning and go to the office, because I know this is the kind of work and it's just a pleasure as the US government to be a part of that journey with you, and just want to thank you for allowing us to join you in that effort.
Thank you. Thank you very much. I'm looking at the audience. I don't see any more hands. So I'm going to go ahead and ask you to join me in clapping for our panelists here. Thank you very much for your time and your knowledge. We are going to take a tea break, and we'll be back at 3:30. Tea break until 3:30. The 2 individuals who won the trivia, I'll be right at this desk table. Please come find me.
It ain't over.
Black mamba, the body speed, the body say you want feeding black mamba, the body speed, the body say you want feeding black mamba, the body speed, the body say you want feeding black mamba. Don't like girls who talk too much. Boys don't like girls who talk too much. Boys don't like girls who talk too much. Talk too much. Talk too much. Girls don't like boys who talk too much. Girls don't like boys who talk too much. Girls don't like boys who talk too much. Talk too much. Talk too much. Boys don't like girls who talk too much. Boys don't like girls who talk too much. Boys don't like girls who talk too much.
Employers see tons of resumes every day and don't have time to carefully review them all, which means that one tiny mistake can get your resume trashed. Get the confidence of knowing you have a mistake-free resume during your job search with help from America's best resource for job seekers. Quickly choose a professionally designed template with one click. Then use our career-specific examples to fill in your resume. No writing experience required. Catch and instantly fix formatting, keyword, and grammar mistakes with our easy-to-use tools. Plus, get expert phrase and keyword suggestions that'll help your resume get past the automated screening software, be noticed by hiring managers, and move your name to the top of the pile. Resume Now is your fastest way to a mistake-free resume during your job search.
Test, 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 test. Test, 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 test. Test, test, 1, 2, 1, 2, 1, 2, 1, 2.
Good afternoon, Dar es Salaam. It is Friday afternoon. It has been a long week. If you are still with me, you are a champion. And I recognize your dedication and I'm grateful for your attention as we enter this last panel of the day, indeed of the week, the NTD Marathon here in Tanzania. I'm going to take a seat now if we are all ready. Oh. I think we just need our interpreter, please. Interpreter. The translation. Did we find out who won the trivia? We did. Congratulations. Who wants to confess to being the barefoot Contessa winner of today's trivia? Ah, nice job. Remind me your name. I know you're from the Gates Foundation. I've forgotten your name. Alicia? Awesome. Did you choose that nickname or was that given to you? It was automatic. So I must have bypassed something that would have been fun and clever to put my regular boring name on the app. So did you? You were actually Joe? Joe. So good afternoon again, everyone. Samash? Wait. Hello. You are welcome. Good. My name is Lisa Rotundo. I am director of USAID's Act East program at RTI International. And I've had the pleasure of leading USAID NTD. I'm just getting used to having reading glasses. This is fun. USAID's NTD projects for almost 12 years now. And I've been working in NTDs for more than 20 years, which is really a miracle because I'm only 30. So go figure. As we wrap up this week, I have really had some fun reflecting back, at least on the beginning of my career. I was a Peace Corps volunteer in Burkina Faso, and a lot of these questions about this tension between disease eradication and the health system I saw firsthand living in a community in Burkina, working at a health facility, but my objective was to support them with guinea worm eradication, among other things. And I can remember one of the counterparts at that health facility telling me at the time that polio a tout gâté, essentially polio eradication had spoiled everything for the work at the health facility. I don't think I fully understood it at the time, but it has become much clearer to me how the vertical disease eradication elimination programs, while they can be thrilling and important, are sometimes opposed with what we're trying to accomplish in strengthening a health system. So I want us in this final session today to really dream about what this world might be like after 2030. We have a WHO NTD Road Map 2030. We know that if all goes right, Dr. Kabona and the government of Tanzania will have eliminated LF and trachoma as a public health problem by then. Many other countries will be in that same boat. And what are we doing at the same time to strengthen the health system? We heard from our colleagues from Togo, Ghana, and elsewhere of what that means once you have achieved elimination. and what comes next. So yes, we've been talking about the progress in NTDs, more than 50 countries. We've talked about the challenges. We've talked about innovation. And again, I've been working in NTDs long enough that I remember the painful struggle that we faced to try to bring vertical NTD programs under the roof of one integrated program. It was challenging. It still is in some countries challenging. And I think that under that structure of integration, these NTD programs have been a success. But let's be honest, there are missteps and lessons that we're learning, mistakes that we have made, that I think if we're going forward, we have to really consider how we're doing work differently. And that is part of what the WHO Road Map is encouraging us to do it differently. In the early years, the USAID NTD program, you know, we've been focused on a subset of the NTDs, and our very generous funding is limited. And so we focus on certain interventions for those NTDs. And we know that that can't do it all, that can't do it in the long term. And we are supporting a limited number of countries, though we have global goals that we're all adhering to. The next decade is really requiring us to think differently and do things differently. And we know that nothing lasts forever. So this panel of guests that I have here is going to attempt to take us to 2030 and beyond, and really explore what we need to do as a community, leveraging our partnerships, leveraging the successes that we have made so far, and really try to complete the agenda, and at the same time address, you know, build systems and help national programs address the other NTDs, all of the 20 NTDs, and to strengthen a health system to sustain that work in the long term. So let me introduce our guests, our special panelists that are closing out the day. You've already heard from Dr. Ndeye Mbake Khan. She's the NTD Program Manager for the Ministry of Health and Social Action in Senegal. She's active in her community. She cares a lot about her family, friends, and faith. And her favorite dish is Cebujen Jaga, which she invites you all to come to Dakar and try. Dr. George Kabona, you've heard from, is the NTD Program Manager here in Tanzania, the Ministry of Health. He has been thrilled to have so many colleagues and friends visiting Tanzania this week, but he cannot wait to hit the football field as soon as we're all gone. And just like his passion for NTDs, when it comes to football, he's like a little kid. He's just waiting, full of excitement and ready to score some sweet goals. Ms. Lynn Leonard from Johnson & Johnson is the global program leader for soil transmitted helminths. Lynn is passionate about data-driven programming. She's passionate about supply chain excellence. She's also an avid scuba diver and volunteers at a local aquarium. So we can say that Lynn swims with the sharks both week and weekend. Miss Emily Wainwright is the USAID Senior NTD Advisor. And when not coordinating global NTD efforts, she can be found on the ski slopes or enjoying a Diet Coke. And we're not sure if she does it both at the same time. Sure, welcome. We're glad to have you here. Dr. Galbert Fejo. Yeah, thank you. Is with WHO Tanzania and has really made the effort to be with us today. He's not an NTD expert, to my knowledge. He is a health systems expert. He's the advisor for health system strengthening and the team lead for Universal Health Coverage Life Course. He has lived in Tanzania 5 years now, roughly, yeah? And we think he's fluent in Swahili, so we encourage you all to find out. So first, Dr. Khan, welcome again. Congratulations on all of your great progress in addressing NTDs, particularly you know, those that are targeted for elimination. You have made a lot of progress. And at the same time, you're working on establishing the strategic plan for NTDs, your sustainability plan and your advocacy plan. Can you tell us specifically how Senegal is working to integrate services for all NTDs into your national health system? What are your priorities and where do you start?
Donc, merci beaucoup, chère Lisa. Bonsoir à toutes et à tous. C'est avec un grand plaisir que je participe à ce panel de haut niveau.
To participate at this high-level panel. Also, thank you for giving me the opportunity to speak on the NTDs, especially with regard to elimination. I think this is something that is very dear to her, the elimination of NTDs by 2030. Let me come back to what you were just saying with regard to the issue on how has Senegal been able to integrate NTDs in the health system. To integrate the NTDs, I normally, when you integrate this in the, in fact, let me say that for us, we have established a master plan of sustainability and aligned it with an advocacy plan. And in this plan, we put our priorities. We put our priorities and interventions, and this allows us to look at these aspects. And I will look at 3 points. First point is with regard to policy. Just to explain that in Senegal, we took NTD as a priority issue in the health system, because Wednesday I shared with you the issue of integrating MTN in the universal health coverage. It's very important today to take into account these NTDs in the package. So that in the case of mobility linked to NTD, for this to be included. And we signed an MOU within 2 ministries, the Ministry of Health and Community Development Ministry. And also, second point on finances. Today we speak of domestic resources, finances. We need to have budgetary line for MTN, and the reform that we are looking at in our West Africa association, we have put in place a plan that will help us to integrate in the basic health programs. Today, this program has been submitted to the Ministry of Economy and Budget. This is very important for the country, because today we know that there are certain entities that have finances and others don't have any financing. But in our country, we are going towards the elimination of all the entities. We have to find additional finances in regards to those diseases that are left. So in financing, we know that there is prioritization. We prioritize certain diseases above others, and so in terms of on the whole issue of financing, I come back to the issue of integrating this in the health system. We have put in place a project for integrating NTDs in the health system by basing on the existing platforms, that of malaria and nutrition. So we bring the various actors at the operational level. We'll put a pilot project at the district level, and we try to bring this to scale so that we integrate in the system. So at the operational level, at the decentralized level, we should integrate NTDs in everything that we do, supervision, coordination, on everything that we're doing. We're doing everything in order to integrate NTDs. Today, you heard colleagues, we speak of elimination, but after elimination, if there is no integration, then there is a risk of a resurgent. If there is no monitoring, there is a risk of a resurgent. So this is very important today to work on sustainable integration, mainstreaming, and this is what we should take into account with regard to NTDs. Now, what are our priorities? Our priorities today is that we should look at the multi-sectorial approach. This is very important because MTN, today we have a plan or a we need to strengthen the multi-sectoral collaboration. In Senegal, we have looked at malaria program in the same system. We think we should integrate the review at the district level, and we do this in data sharing for malaria, and so we should integrate this within the Ministry of Health and outside the Health Ministry. I think this is very important to underline. And the budget, it's important when we integrate MTN, we should integrate this in the draft budgets. This is very important for Senegal.
I wanted to hear a bit now from George about
Dans l'expérience de la Tanzanie, vous avez parcouru
the pathway to getting to sustainable NTD services. We heard a little bit about that already just now with our colleague from Peel Rouge. What I love about the Tanzania story is their commitment to try different things. And I think it's a mistake that we make too often because we don't know the perfect way to start something. We might hesitate or not start at all. Dr. Kabona, I'd love to hear about how your program's efforts to increase district level planning and financing for NTDs have been received at the district level and at the national level. What have been the successes and your challenges at getting greater visibility for NTDs across sectors?
Thank you, Lisa, for a good question. As you have just highlighted, what has been done with regard to health system strengthening, particularly domestic resource financing, we have seen from the previous presentation. But now the question is, how did they perceive that process? Actually, as you can see from the evidence, that there is some progress on increase of domestic funding. Actually, the district team, one of the things noted is they didn't have the capacity of ability to plan for NTDs. That's why we started with the piloting. Those 15.6 by capacitating them on NTDs, planning and budgeting, and this was done in collaboration with the Department of Policy and Planning, also the PORAJ, and then we allowed them to go and do the budgeting. You could see that change. They were able to increase the budget for at least 12%. And actually, one of the discs, the budget actually went twice as much compared to the previous year. And one of the planning officers from the council actually commented, this has come very late. We have been doing the MDA, the interventions for NTDs, and without knowing that we can do this. And therefore, he was excited for it to just being scaled up to other countries, other districts, so that all of them come on board and make sure that there is something being budgeted or planned for NTDs. That's that's the substation. So they're excited and they're happy and they're looking to work, and we are very much collaborating. You can see from the presenter from the PORAJ, the team is very excited on NTDs mainstreaming into the planning and budgeting system. Now coming to the national level, this is over, starting with the Ministry of Health. We know we started the idea of sustainability plan by doing the situational analysis with the support from USAID. And after the situational analysis, the process of developing sustainability plan was all the guidance come from the directors of policy planning at the Ministry of Health. So everything which is seen written in the document actually is with the guidance from the Ministry of Health. So the Ministry of Health is 100% responsible for what is there, and it is really fits in what is needed with the country's sustainability plans and goals. And we also engaged the PORAG ministry, which, as we say, is an implementing arm of the country. And this has been instrumental in kicking off the implementation of sustainability plan. How did it start? Because the sustainability plan has a lot of interventions or objectives to cover, and we had just to prioritize some of them, which among them is increasing domestic financing, starting with the local government authorities at district level, and while advocating for also for community empowerment through other through other interventions. And therefore PORAG initiated the planning by conducting this pilot. As you have seen, the pilot started with the 15 districts where you have seen the changes, and after we have evaluated and saw those success, we had the pause and the reflect meeting together with the PORAG, Ministry of Health, and some people from the Ministry of Finance and the Director of Policy and Planning at the Ministry of Health, whereby after that meeting, actually the PORAG was really excited and committed now to start to take care of everything after that. And one of them was to start mainstreaming the NTDs activities or the NTDs interventions within the planning system of the PORAG, which actually guides the council health strategic planning, council comprehensive health planning at the district level. And some of the activities we have seen, developing the indicators, which are supposed to increase visibility within the plan rep, that is the planning system for the PORAG, and also creating criteria for assessment, because after the district's plans are complete, then the PORAG ministry conducts some assessment, and NTD even had no criteria of being assessed how much has been budgeted and why. But now the PORAG has led that exercise. We have the indicators, and now they are in the process of being incorporated. So in a few times we'll have, in a few moments, in the near future, we'll have the NTDs visibility very clear, and how to monitor and assess, and using the criteria which tells how much has been budgeted and why, and it can be one of the criteria to either approve or not approve the district council health plans, which is a very, very big step. Now, apart from that, those indicators will also, we have actually conducted the financial analysis activities led by PORAG. This was a very important activity to just try to establish the level of budgeting for NTDs, which has been happening, but also a point where to start with, or an evidence to try and address some changes within the financial system guideline. That means at least to put some proportion of how much of the funds should go for NTDs. And that one is almost done, and probably the process of processing it to effect on the guideline is underway, and the team actually is leading the process, which is very important for this sustainability. So that is how the national level has perceived this process of sustainability, and particularly the domestic resource mobilization.
Great, thank you, Dr. Cabona. So we've heard from two of the endemic country program managers. I'd like to come to WHO now, if I can, with the role that you have of guiding the member states, providing leadership and direction for them. Love to hear more from you about how you would recommend vertical disease programs think broadly into integrating their services into the wider health system.
Okay, thank you very much. For the integration specifically, I would say that, I mean, we had a very nice pilot project in Tanzania, as it was mentioned by the head of the program, but this should have been started much more earlier, because most of the time we start these interventions later. Programs do not speak together enough, I think, and this should be avoided. I mean, if we really want the interventions to be sustainable, and if we really want a good integration. Fortunately for Tanzania specifically, there is an opportunity, because there is an ongoing initiative at the Ministry of Health of developing and implementing a national accelerated plan for quality of care. And they are really taking into account all the aspects of the quality of care to improve the curative service. And we know that unless people are really confident in the quality of the curative services, they are reluctant to take the preventive one. I think that this will really give the opportunity to Tanzania to address this issue more holistically, especially the issue of training. We are on track for the elimination of many of these NTD. I can say that, but this now I can be challenged because you have your opinion, but when it comes to calculating facts, sometimes it may be different. I remember this week I was working with some of my colleagues, and we were trying to see if Tanzania will achieve the sustainable development goals with a mathematical model. And we realized that it will be achieved in 2056. And we were one of the best in the African region, because that was done for the whole African region. But if you ask my own opinion, I think we are on the track. I mean, I'm confident. I'm a little bit confident. But this will happen only if we really ensure that the NTD are included in the benefit package of the National Health Insurance. It will not be, it is always not easy to convince people to include the NTD in this package. But by really estimating the benefit to affected individuals, I think there is a case for advocacy. And if also the resources of the donors are channeled through innovative purchasing mechanism, including targeted intervention to provide health insurance to the poorest in the population, yes, we can accelerate the elimination of or the control of most of the NTD. We know that even if when the health insurance bill will pass, it was already submitted to the parliament last year in Tanzania, and even if the health insurance is not mandatory and we are still going for a voluntary scheme, the poorest will not be insured, and the poorest are exactly the ones that are the most affected by neglected tropical diseases. So in summary, I will say, okay, there is opportunity for integration. Unfortunately, usually the integration start only when the resources are becoming scarce. But hopefully, with the other ongoing initiatives in the country, we will get there. Thank you.
Yeah, thank you. We're, again, very pleased that you could join us today. I want to follow up and just ask you if you have any more thoughts about what WHO could do, whether at the country or other levels of WHO, to support a national program manager in this, whether it's here in Tanzania or elsewhere. Your message about we need to start earlier. We started too late in some countries. How can we achieve that elsewhere?
Yes, I think one of the key supports of WHO, and this is something that is lacking in most of the country where I've been working, is the modeling. Really providing data. I was talking about my opinion versus the facts. I mean, providing facts to the government and telling them, unless you do this, you can be sure that in 2030 you will not achieve your target. That message can really wake up the policymakers and the decision makers. The advantage of having of the modeling also is that it highlights the shortage in terms of information available. What are the data that we need to really track the achievement of our objectives? Because when you look at some of the objectives of some of the NTD objectives, it's clear that we have no mean to measure. If let's take the target of 75% of people of reduced disability adjusted life, I'm not sure any African country can measure this data. It doesn't mean that it is impossible. If we see the pace of using the mobile money in Africa, it means if there is a political will, if, for instance, not only WHO, but USAID and other donors, if we really invest in digitalization, in supporting community health workers with all these electronic devices to report from the community level, I insist on that, not only at health facility level, but from the community level, yes, that will probably improve the awareness, but also improve the surveillance, and we will get it that to really inform the decision making at country level. My opinion is that having these data really of great importance when it comes to coordination, because when we are in the meetings of the donor, it is always my opinion versus your opinion. Nobody said, I'm saying this because these are the facts. And sometimes, even if you provide the data, someone will be able to challenge the data that you are providing. And at the end of the day, we will not take informed decision on it, not only on NCD, but also on other aspects of the health system.
Yeah, thank you so much. I have more questions, but before we run out of time, I'm going to move on to Lynn. The pharmaceutical companies have long been important players in NTD control and elimination, and Johnson & Johnson started in 2006. So around the same time as the USAID program starting, now having donated more than doses of medicine. So we applaud your commitment and the work that we accomplish thanks to that, but no partnership, of course, is perfect. So if we're going to achieve the roadmap goals for 2030, what do you think are the most important priorities that we need to address and changes that we need to make? Thanks.
Great. Thank you so much, Lisa, for that question. And thank you, USAID and sponsors of this meeting, for inviting me to represent pharma on this panel. We sometimes feel like a little bit of an odd man out in this environment, but the truth of the matter is we are quite proud to be here and really proud to be able to participate in the program in the battle to fight NTDs. This program really is quite near and dear, or the program that I run, which is the mebendazole donation program, is near and dear to J&J. And we fully recognize that it's only through cross-sector collaboration that we're able to achieve the progress that we're reporting on today. However, as Lisa mentioned, it's not always easy and there are challenges. And as we look forward to the goals that have been set forth in the 2030 roadmap, they're quite lofty. And there's a lot of concern about the sustainability. And, we're hearing all the challenges associated with getting us there, that perhaps that we're working behind. We're already late to the party, so to speak. And from the pharma perspective, it is becoming a real challenge to keep our senior leaders engaged in being donors. And so for that reason, I think the key priorities for achieving the goals of the roadmap as it relates to pharmaceutical donors really fall under the umbrella of what I'd like to call responsible, I'm going to say that word twice, and equitable and evidence-based use of the donation. I say the word responsible, and I wanted to repeat it twice because donations really are a privilege when you receive them. And too often we're seeing and reporting expired drug, poorly stored drug, and that's a loss, not only from a financial loss, but it's a loss for all the people that didn't benefit from receiving it. So I'm making a plea for those of you who are in countries and those of you who are implementing partners and have the capacity to influence and accommodate what is responsible use of our drug. And that includes not only the distribution of it, but inventory management. Let's use a first expired, first out system and really ensure that we're getting the best out of all of those donations. Then when we think about equity, which is always a hot button, I'm tying that in with the idea of evidence-based utilization of our donations. I think when the program started so many years ago, I know for STH, it was really like a simple equation. This is how many school-age children you have in a country. We're going to dose twice a year, and that's how much drug we shipped in. J&J is 17 years into this program, and we know that progress is being made. We funded studies, as well as many of the organizations in the audience have funded studies, and we know the prevalence is coming down. We really need to be more active about taking that data and incorporate it into what is actual drug need within country. So I'm talking about data, using those data-driven insights to define what is country need for STH. And this is not unique to STH. Other programs are doing similar things. And in that way, we really want to maximize the value of what donation is available today to reach the largest amount of people. And that's what I'm talking about equity. You don't want to have one country ordering inappropriate amounts of drug, maybe not even using it, all of it, seeing it, expiring it, where there's other countries that will not have access. So think about it in terms of be responsible. Let's be, thoughtful about utilizing the data to maximize the value of the donation you have today for optimal health impact.
Great, thank you. And to move to Emily, again, 17 years USAID's commitment, and as a big and long-standing donor and technical supporter in NTDs, we've seen this shift in the last 5 years to an increased focus on sustainability. Maybe better late than never, but we're well in it now and we're learning a lot. And you talked in the previous session already at length on that. What would you want governments to know about your partnership moving forward? Governments or the audience here, when you think about 2030?
It's been interesting listening to a lot of the commentary today, and thinking about what does that mean for 2030. And I think as a donor who has the privilege of working with many of the governments, there's this tension. The first half of the day was very technical. The second half of the day, we're talking about systems. I think we've in the past, as many people have alluded to, had a very simple conversation, right? In the beginning, we need a map, we need to get MDA going. And now the problems, all the final mile problems are coming up. What are we measuring? How are we reaching mobile populations? Are the tools right? It's getting very, very technical conversation in some ways. And I feel like we've kind of need to catch up to where we are. If we're going to get to 2030, we need to finish, we have this great opportunity with pharma. We have to finish that and take advantage of it while we have it. And to Lynn's point, use it as appropriate as possible. So for us as a donor, we want to continue that conversation, and we want to continue that support while the opportunity exists. But I think governments have also been showing, in many ways in this conversation, they're way ahead of where we are, right? Being part of the sustainability planning is great, but I'm looking at governments who are like, we're out here, we're looking at our health insurance schemes, we're trying to figure out financing and policy change. We need to catch up with that conversation, and it's like, how do we balance working on what we've done in the past and continuing to work on that, and then open the door and look at broader thinking. And I really look to the countries to say, help bring us along. Like as a donor, this is what we want to do with the partners we have. We want to be a part of that. But I'm hearing across the board, we need a broader, more diverse partnership to get the job done. We've been looking in our space, but you think about Tanzania and the policy changes that are happening. You look in Senegal, the changes that are happening. We need to engage with a different set of partners and be willing to work with them in a very, very different way moving forward. And so I think we need to learn and figure out what is that balance, so that we finish what we've started, but also open up the door so that we're engaging other things. I've sat and, the US Congress helps focus us on using the US dollar to help address the PC diseases and tackle the elimination of the diseases that do have a donation program. But how many years do we hear, what about the other diseases? What about the other diseases? What about the other diseases? And this is the door and the opportunity. And so we want that partnership with governments to be able to unlock that, because I do not think there's a world where there's going to be a series of disease specific elimination programs. I think it's to what WHO says. And what the NTD program manager is saying, that we need to look at a different model of doing business. And so wanting to do that. But I think, we need to be this in a very real-time learning mode about how do we achieve that collectively.
Yeah, excellent. Thank you, Emily. I want to turn back to Senegal and Tanzania and see if you have any other thoughts or responses to provide, given what you've heard from colleagues.
Yeah, thank you. Actually, thank you for Emil, and that's what is happening. We are still more on the actions and switching to the impact, and the way we are approaching how to get to the impact. There are things which really need to be taken on board and probably given the priority, so that they are really connected to the shift of approach from the WHO roadmap, which embraces cross-cutting, country ownership, and also the accelerating programmatic actions. And as a program manager, I could see with those three pillars connected to those shifting approaches, and the approach which we can take as while mainstreaming or caring effectively with the health system training is some sort of bottom-up approach. More of the investment should be from down upward rather than from the top to downward. That means you have to strengthen whatever we are strengthening. Should be the community level should be the starting point to develop those approaches. And for example, for the mass drug administration, for it to be regular and effective, that means to reach those who have been consistently missed, to reach those special populations never treated, and so like we could see this can easily or better be addressed if the approaches are thought from the lower level and going upward, and so that we don't leave the community's perceptions and the community's context or the local context actually for the one who are affected on board, and therefore for what I would like to see happening before the 2030s. Yes, we've been doing very good job and we can see the impact, I can see the success, but according to the target set with the roadmap, most of them is about elimination, and therefore we need to make sure that everyone in need is protected or prevented from getting or being reinfected and lead to the persistence of infection, or is not missed out from the interventions. And therefore I would like to see there is a robust M&E mechanism which can track the progress, which you are really doing it, but maybe the approach and which can really identify the areas to improve and ensure accountability, and this accountability actually is from the lower levels. Also, we know the surveillance system is very critical for where we are, and little is being done. Yes, we have some investment, but not that much. For example, in my country, we have some districts which have eliminated diseases since 2015, 2016. I don't know what is going on. Nobody's talking about it. But people are there. We don't know what they're suffering. And so that's our weakness. Not everybody's weakness, but maybe the approach, which I'm trying to show that probably we are just not discussing those people. Are we really on the right track? Maybe something it need to be done better in order that we don't leave those people whom we think we are done with elimination, and yet we are not monitoring in terms of infection, but all other possible indicators for the absence of the disease. Yes, we have eliminated the disease, we have eliminated the infection, but we have some cases which are there. Have we strengthened the health facilities? Can they access diagnosis, treatment, and probable care? Especially those who are living in very remote areas and they are underserved, the places where the health system is not the best, probably even for these prioritized diseases. How about our neglected diseases? Then that's where we can see how the thinking should start from bottom going backward. Then we cannot leave these people.
George, I might need to give the final word to.
Thank you. And the last one is just on engaging the community and also strengthening the multi-sectoral collaboration, but without forgetting the cross-border issues. Thank you.
Yeah, thank you. I would love to hear from Senegal in conclusion. The multi-sector collaboration that George started to talk about, what does that look like for you for 2030 and beyond?
Donc, merci pour répondre à cette question sur la collaboration
multi-sectorial collaboration in Senegal. Just to remind you that this is an opportunity that was given by the WHO Road Map earlier on. We talked about cross-cutting approaches, and I would like to say the integration of services, multi-sectorial collaboration, involvement of country on universal healthcare. And it is in that optic that the government has put a multi-sectorial approach with 6 committees. Recently, we've had a meeting with the WASH committee, which was 6th of July, and at the moment we are developing an integrated data collection for WASH, and we are working on a framework agreement, because very often we talk about multi-sectorial approach, but we need to go further. That is why at the moment we've already drafted the framework agreement on 3 sectors: the education sector, and WASH sector, as well as health sector. It's important because nowadays we need to have under these ministries, because under the Ministry of Education, we have a person that is in charge of NTDs, but also the Ministry of Water. It is the same thing. For me, with the action plan that has already been prepared by the committee and chaired and validated by the Permanent Secretary of Ministry of Health, and this is important in terms of multi-sectoral collaboration. But today we need now to move towards innovation, to put in place actions in terms of synergy of actions for this collaboration. Everyone is involved, but we need now to go towards the operationalization, decentralization of this multi-sectorial collaboration at the level of regions and districts. That is why in Senegal, we've put in place a master plan, but we should not limit this to at the central level. That is why we have initiated at the level of the region with the other sectors to share this sustainable plan, to work with all the sectors at the operational level. This has allowed us to develop what we call our operational plan, so that people at the decentralized level are able to have ownership of this master plan to take actions. Today we should talk about ownership. We tend to talk about sustainability, but without ownership, we don't have sustainability. And ownership is at all levels, by beginning the community level, the regional level, at the level of Ministry of Health, and even higher. We need to have ownership in order to ensure sustainability in the fight against NTDs. Now, when we come back to collaboration with the Ministry of Education, we understand that today we are already working in the, as we are moving towards the implementation, we should be able to continue to treat children at schools. That is why we've developed a framework so that teachers are able to have ownership in order to ensure the sustainability. And all this, it's in the framework of multi-sectoral collaboration. And today, the priority is to fast track or accelerate the elimination of NTDs. But how to go about it? This is when we need to reflect. And to answer this question, we should move towards synergy of action, innovation action, how to involve everyone in this fight, in this multi-sectoral approach. In this multi-sectoral approach, we should also take into account other sectors such as higher education, research, to support the NDT approach, to see how we can reorganize our interventions in the fight against NTDs, but also to see how to coordinate. In Senegal, every 2 semesters we have a coordination meeting by involving all sectors, and this has allowed us to advocate. That is why today the Ministry of Economy is ready to support us in this project, because we started by inviting them us in our actions. We advocate, and they also take part in our coordination meeting. We also have other sectors within the Ministry of Health that will take part, such as Department of Planning, etc. We share our work plan with all the other actors so that we're able to coordinate all the actors. Each year, we prepare a work plan where all the intervention of all the activities defined by the partners are incorporated in the plan. Every 2 semesters, we also have a follow-up on this work plan that is known as and this is important, to bring together the various partners and stakeholders to discuss on the fight against NTDs and how to fast track the eliminations of NTDs. I believe, I know that our priority today is to fast track or to accelerate the elimination of NTDs. How? This is where we should really put an emphasis through this multi-sectorial approach, resource mobilization, ownership, leadership. And I believe if we are able to put together everything that we are saying and doing, we will be able to go towards to put an end to NTDs by 2030.
Please join me in thanking
moi pour remercier les panélistes.
We know that we will accelerate towards elimination.
Nous allons
Elimination as a public health problem is, of course, a reversible condition. So we will be cautious and we will learn and we will dream together. It's been a thrill to think about what 2030 might look like, and engaging all of these other sectors and new experts personally for me is going to be very exciting. So thank you all, and on to our next session. Final session. Yes.
Hello. Okay, we are quite there. I think that was a tremendous panel at the end of the day. Very productive day, very engaging, and I think and I hope that you like it as I did. I don't see smiles in your face. Thank you. So you did. So we will now hear some closing remarks from USAID. It's my pleasure to welcome Rob Henry to the stage. Rob has been a steadfast champion for NTDs for many years. Rob is a public health professional in the truest fashion. He's a practical, solution-oriented. He is deeply committed to solve the challenges facing us in achieving elimination. And I know what I say, because in Mozambique, we've been doing concrete things last year, increasing and adding LF. So we've been also delighted to have him as our lead as USAID Act East. Welcome, Rob, to the stage. Thank you.
Hi, everybody. Again, I'm Rob Henry with USAID, and I got the easiest job of all these jobs, which is to wrap it up. So that may actually make me, depending on how long I go, it may make me the most popular or the least popular person. So they try to manage me very well, which I deeply appreciate. And they gave me a list of reminders. I think it's always important to thank people, and I said I would do it. And then they asked for my closing remarks, and they never got them, because you never know what you're going to say until you get right here. So I will pay for it later. So first of all, may I just ask us all to give a round of applause for yourselves and for each other for not only today, but this entire week, which is, I think, has been really an excellent experience. I'm very glad that we have had it. And so for all the speakers, the moderators, the presenters, including our Ministry of Health representatives, other ministries and government offices. Pilraj, I see you over there. Thank you so much for all of the input, and for all of the others who brought questions and other feedback, which is what I was really after. I have a little story about that. The government of Tanzania, absolutely, for hosting us in their beautiful country, for NNN for allowing us to help attach this to the end of their meeting. And so that we can have the For All to Thrive event today. And then, of course, to the Act East and Act West programs, who really stepped up and brought it together. I really appreciate it. I have a long list of people, but really I'll just say that there were so many more that are on my list, that everybody that just stepped up, did all the planning. You know, when this was first conceived, I would never imagine like how well people would come together and to work on this. And I'm really very, very grateful. And then we had the people that did all the logistics today. I think that all went really very smooth. I appreciate it. Maximize your time, the AV team, all the people here who helped us do that, the interpreters back there, even though we sometimes didn't turn on our mics, you kept up, and keeping up is not easy to do. Yeah. And then finally, to all participants in person and virtual. All right, so that's all that's prepared. Okay. Yeah, so I just first of all just want to say that I really appreciate this. I have a little backstory. So this has been about a year and a half or so ago. This was an idea that we sort of talked about in the work plan. And I know Liz, Edie, and I were really sort of like talking. She doesn't want to, don't attach her name to my blame, but we got it going. And then people brought the ideas together. And I did some fighting to like make this happen. I pushed and I urged and I motivated in my own special way. So it's not about me, but I'll just say that I have to say, even until I got here, I wasn't sure, like, did that do the right thing? But I feel like we really did the right thing. I was so glad to have this opportunity because after 5 years of working, the countries, the implementers, all the other people that wrap around to make this all happen, and there are a lot of people that wrap around this that we never even talk about sometimes here. Really, there's just so much to share. I mean, progress is great. And I, having been in NTDs now for about 8.5 years, I've been really impressed with a lot of the progress. My job has primarily been to push for beyond progress, to get more progress, to get somewhere else, and to just see those things move. It's just been tremendous. And I'd like to share that out. And so that others are hopefully inspired and will also share theirs. There's also a lot of lessons learned. The fabulous 5 fails that Mike had to do, because I opted out, because why? Getchy asked me. I said, because I'm the AOR. So, but I was really glad to see it because, failure is how we learn sometimes. And it's really, if you just stare at your navel or just stare and worry, as somebody said earlier, about doing the wrong thing, you never really learn what you can achieve. And so there is some of that. So through failure, we learn. And the learning agenda that Act East and Act West has been doing has really been something that I've been really happy to see move forward. But then the other thing that I really love about this is I really saw this line of sustainability come through. And this has been something that was just a little glimmer a couple, 3 years ago. And now it's started to move into a direction where it's actually something that makes sense, tangible. I'm a very concrete person, just like the material that makes up a lot of the buildings. I have to see things on the ground in action working. Otherwise, it doesn't matter a lot to me. I just don't connect. I get bored and I walk away. And I've done that before, but lots of times. But I really am starting to see this in countries in ways that work. And it's really nice when people, first of all, who argue at me, it's like, I don't know about this. And then they start to say something like, you might have something there. That's also like rewarding to see that go. But I think we have an awful lot of work to do. That's the other thing. So we still have a long ways to go on the elimination challenges. There are these really tricky things that we're trying to do with trachoma and LF and onco, of course, really trying to get there. But we're really pushing. I think that by learning, by failing, even if we fail and we share what we failed on, I think we help all of us move forward. And that's what my commitment has been, not just for the countries that are in Act East and Act West, but for all the countries that are part of these efforts is what I hope that we will do. And so the sustainability piece, I think, is really important for those diseases that will be left behind, not just the ones that are in sort of USAID's 5, but in the larger context of the NTDs, that we can help bring those into the systems, really use the platforms that are there and give them the attention and the actual services to the people that actually need them. And so that is something that I hope will be left as we continue to move in this journey. And so I think, and now in my mind, I see that Act West had this great cartoon where the guy got to the finish line and somebody moved the finish line. And I promise not to do that. So I'm just going to stop there. I'm going to say thank you again, all of you, for your time, your attention, your input, your energy, all of it. And I'm wishing you all safe travels home if you don't live here, and asante sana.
So when you work for the U.S. government and you have lots of implementing partners, there's an in-house joke about there's an in-house joke about being managed up. So some days we're working for Rob, some days it's vice versa, but frequently implementing partners are telling us what to do. So I have been told what to do today, and a request has come in from the head of the Act West project that I think would also from Act East is that we just take a moment to acknowledge that Mr. Henry, who has been running an amazing project for the last 7, 8 years, I can't remember, is going to be going off to do greater things in 2024, including skiing and scuba diving and doing all sorts of fun things. And we would be remiss if we did not take a moment to thank you for all the hard work, the perseverance, and the humor that you have made possible for us. And so thank you.
Thank you. Thank you all. It's don't start. I'm not going to do another speech. I'm done with that. Just to quickly say thank you all very much. I really appreciate it. And if I may, and I really mean this, I've worked on several public health programs, and this has been outstandingly my favorite. It'll be rest in my heart for that, not for just being the last one that I'll work on in my federal career, but really the one that really just energized me in so many ways. So thank you, and thanks for that warm remark. Thanks.
The rapid fire. Okay, thank you so much. The day was great, and the session is closed. Thank you.